Hello everyone, this is your voiceover for your respiratory content for 202. And this content, we are going over pleural effusions, respiratory failure, acute respiratory distress syndrome, also known as ARDS, mechanical ventilation, and tracheostomies. And here are your readings, all in Lewis. It gives you your chapters and page numbers. Okay guys, so jumping right into pleural effusions. So first of all, we need to kind of know where the pleural space is, right? So in this picture here on the slide, it's showing us where the pleural space is. So if you look in on like the magnified version here, it's showing you on the left side we have a parietal pleura. Then we have our pleural space, which is the purple. And then on more towards the right side, we have our visceral pleura. So parietal pleura is actually kind of more attached to your chest wall, right? And then it goes your pleural space, is that small space between your chest wall and the lung. And then on the right side of that pleural space is your visceral pleura, okay? And that visceral pleura is stuck to the lung. So think of visceral organ, that's kind of more part of the lung. Parietal is more on the outer edge, that's more of your chest wall. And then your pleural space is right in the middle there. It's a very thin space. So kind of getting right into these questions, how much fluid should normally be in the pleural space? And that would be 5 to 15 mLs is normal to have in there. And why do we need this fluid? Okay, what does this normal fluid act as? This acts as a lubricant, okay, between the chest wall and the lungs. So as your lungs expand and contract, it gives it that lubrication and provides less friction when we are expanding and contracting while breathing. So what is a pleural effusion? It's an abnormal collection of fluid in the pleural space. So anything over 15 mLs, right? Okay. Anything more than the normal. Okay, guys, so next we're going to talk about movement of fluid in the pleural space because we kind of need to understand why our lung is going to fill up with fluid and cause a pleural effusion. These three pressures, typically maintain a pretty good balance and they govern the movement of fluid from in and out of the pleural space, and they're normal. It's when they're either like increased or decreased is when we see problems happening and see increased fluid in our pleural space when these pressures become abnormal, okay? So pulmonary capillary hydrostatic pressure, we have this every day, okay? This is a normal function in our body. So it's when a force of fluid in a compartment is pushing against the cell membrane, okay? So it's causing a lot of pressure, pushing against the cell membrane, and it's actually pushing water, a little bit of water out from the vascular system into our interstitial space. So it's that great pushing force, okay? That can be just from like blood pressure or, kind of more normal things that are happening in our body. But if we think about something abnormal going on, we're going to have more of a force, okay? More of an exertional force than normal. So if we have more of a pushing force, we're going to have more fluid being pushed out into our interstitial space than we want, okay? So typically, normally we have a great balance of that force and that pushing pressure. It's when it gets a little bit too high is when we enter that problem of fluid entering our pleural space a little bit more than we want, okay? A good example that I can think about of this for a higher exertional force or pushing force is possibly heart failure. So our heart's working a little bit harder, it's pushing a little bit more force, into from our vascular system. So it's pushing water out of the vascular system and into the interstitial space. So that is pulmonary capillary hydrostatic pressure. Next is oncotic pressure. So oncotic pressure has a lot to do with protein like albumin. Okay, so oncotic pressure is a form of osmotic pressure. It's caused by proteins such as albumin. So if we think about it, our blood and plasma, it's chock full of proteins, okay, and albumin. Our interstitial space does not have that, okay, at all. So what's going on in normal oncotic pressure is that when we have the plasma proteins or the albumin, plasma proteins attract water. So if you think about it, if it's attracting water and the plasma protein, such as albumin, is in our vascular space, it's going to pull that water from our interstitial space into our vascular space. That's kind of where we want more fluid to be, right? We don't really want it in our interstitial. We want fluid a little bit more in our vascular space, all right? So think about that one for a little bit. And then you guys are a little bit more familiar with capillary membrane permeability, right? Okay, and this happens every day too. This is a normal occurrence in our bodies. And it's the capacity of the blood vessel to allow or flow like small molecules and water, even whole cells in and out of the vessels. And that's normal. It's when we have an increase in capillary permeability is when we have problems, okay? So I think I answered a few of the questions here. Um, so out of those three pressures, we're going to talk about what would cause increased fluid accumulation. So if we're going back and we're talking about the pulmonary capillary hydrostatic pressure, would that pressure be higher or lower if we're going to have more increased fluid accumulation in our pleural space? We're going to have a higher pressure, so we're going to have a higher pushing force, right? So that high pushing force, which is abnormal, is going to exert more water into our interstitial space from our vascular system, which is going to cause increased fluid accumulation in our pleural space, okay? And it's from that increased pressure, okay? Even more than what our body is normally used to day to day. And again, a great example of that was heart failure. So moving on to oncotic pressure, would that pressure be higher or lower for increased fluid accumulation? So think about that one. This is going to be a lower oncotic pressure, okay? So we're going to have, for some reason, we're going to have decreased albumin. So we're going to not be pulling as much water into our vascular space as we should be. And that water is going to be staying in our interstitial space because remember that water attracts to the protein or albumin. So if we have a deficiency or a lower pressure or lower albumin, we're not going to have that attraction of water to the vascular space, and we're going to have the water maintained in our interstitial space where we really don't want it to be, which in turn is going to cause increased fluid accumulation in your pleural space. And then you guys know this one, so capillary membrane permeability, and we know that's going to be increased, right? So we're going to have an increase in capillary membrane permeability. That's typically from an inflammatory response or inflammatory condition. And our capillaries get very, very permeable, okay? And it's a little bit easier for fluid to flow out into our interstitial space, and again, causing increased fluid accumulation in our pleural space. So we're going to talk about two types of pleural effusions. There is transudative effusions and exudative effusions. So in transudate, we have an effusion that occurs in non-inflammatory conditions. This involves an accumulation of protein poor, cell poor fluid. So think about that. We're thinking about protein. Okay, that's reminding us that's probably talking about albumin. So we're going to have issues with albumin, lower albumin. So again, going back to those pressures and thinking about what's causing this type of effusion. If we were to take a sample of fluid from the pleural space and it was a transudative effusion, we would typically see the fluid to be clear or pale yellow in color. Um, a main factor contributing to a transudative effusion is an increase in hydrostatic pressure. Again, a great example that we typically use is heart failure. So we're going to have that increase in hydrostatic pressure. We have that pushing force of fluid into our interstitial space from our vascular space. And we're going to have a decrease in oncotic pressure. So remember, that one has a lot to do with albumin. So we're going to have issues related to hypoalbumin. We typically find this a lot in liver disease patients, cirrhosis, or renal disease patients, or nephrotic syndrome. So remember, when we do have like that, acute kidney injury or acute renal failure, even in chronic renal failure, what do we see in our urine? We see a lot of proteins fall through, right? Okay. And we're going to lose a lot of albumin typically in our urine for renal failure. So that's just the reason why we would have a decreased albumin levels. Okay. And then we move on to exudative effusions. So this one is resulting from an increase in capillary permeability, and this is due to inflammation. So transudative is non-inflammatory, exudative is from an inflammatory issue, okay? Inflammation of the pulmonary capillaries. What happens when there's an increase in inflammation in their capillaries? Our capillaries become leaky, right? So fluid will flow out of the capillaries and leak into our interstitial space, or, really in this case, our pleural space. If we were to take a sample of this fluid from our pleural space, this would appear cloudy. So inflammatory issues or exudative effusions will have cloudy fluid. It's very common for patients who have infections to develop exudative pleural effusions, a trauma, or cancer. There are a few other reasons why we could have increased fluid in our pleural space as well. And the other one is a chylothorax. So this is actually when the thoracic duct is disrupted or there has been injury to the thoracic duct or trauma. This has a lot to do with lymphatic fluid flow, okay? So what's going to happen is lymphatic fluid accumulates in our pleural space when we have a chylothorax. So there's either been damage to our thoracic duct, it could be by surgery, could be by trauma, or it could be even by a tumor. It places a lot of pressure and compresses on our thoracic duct, okay? And it's not flowing properly, which is causing accumulation in our pleural space. And if we were to take a sample of this type of fluid from our pleural space, it's actually going to appear very thick and milky. It'll appear just like milk. And then lastly, we'll talk about empyemas. So an empyema is actually a collection of purulent fluid in the pleural space. It's a very infected fluid and pussy fluid. This is typically often caused by a pneumonia. It could be caused by tuberculosis. Lung abscesses are very common with empyema. Infected surgical wounds of the chest. These patients are going to need long-term antibiotic therapy for sure. And also, something to think about is percutaneous drainage. By either placing a chest tube or even going in for surgery and doing a VATS procedure, which is a video-assisted thoracoscopic surgery. Especially if there's like an issue with lung abscesses, this would be, a huge need to be surgically removed. So clinical manifestations of pleural effusions. So the patient's going to be short of breath, okay? They're going to have dyspnea. They're going to have a cough. A major determiner of pleural effusions typically is pleurisy, and that's while the patient is inhaling, they're going to have severe, sharp pain with inspiration. Okay, pain in the chest with inspiration, and that is known as pleurisy. You'd hear decreased breath sounds, decreased movement of the chest, especially if there was an affected side over the other. You notice a little bit of a decrease in movement on the affected side. There'd be some dullness to percussion, so if you were to tap, especially on the back of the patient on the affected side, you'd hear dumbness when you do percuss. And also the patient's going to have decreased tactile fremitus. Okay, so tactile fremitus, it really refers to the vibration of the chest wall. And typically we hear sounds and vibrations created by the speech of the patient. But if you think about this, if we do have quite a bit of fluid on board in our pleural space, and you're going to have that patient speak, do you think we're going to hear those vibrations, or do you think they're going to be dulled? So we're going to have dulled vibrations, okay? So that's going to sound very, very dull. And what happens is the excess fluid is actually absorbing the sound. So they're going to have that decreased tactile fremitus. And in really severe cases where there's a lot of fluid and a lot of pressure on one side of the lung, okay, that lung is actually going to be pressing against the other lung, causing a mediastinal shift and a tracheal deviation. That's a huge emergency, and that pressure and fluid needs to be relieved immediately, okay? Now, if we were going to have a finding of like empyema, what other findings would we see in our patient? We're going to see a fever, right? We're probably going to see a fever. We'll see probably elevated white blood cell counts in our CBC. Might have the patient may go through night sweats. They may be a little tachycardic. So just manifesting signs and symptoms of more of an infection. And then diagnostics. So chest x-rays are a big deal. They're a very helpful diagnostic test and, when taking a look at pleural effusions. So a pleural effusion, it can really settle into our lungs, especially something to think about whether or not the patient's kind of sitting upright, maybe in the high Fowler's position, or whether or not they're laying down. Kind of gives us a good determiner of what that will look like whether in the patient's position. Okay, so just something to think about. Um, if the patient is standing or sitting in that high Fowler's position, that pleural effusion will typically settle into the base of the lung. That's called the costophrenic angle. Okay, it's right along the diaphragm. But if the patient's laying down, that pleural effusion or fluid is kind of going to get more dispersed, right, when we're laying down. It's called layering. So we're going to see a little bit more layering and more evenly dispersed throughout the lung when the patient is laying down. And what we're going to notice on the chest x-ray are typically, very white, patchy consolidations, and where really the fluid fills the space instead of air. Okay, chest CTs can also be very beneficial, give us a little bit better picture if we need one. So both chest x-rays and CT scans, they can definitely reveal the volume and location of the pleural effusion for sure. And then the next few slides, we're just going to go over some examples. So I just wanted to show you an example of what one may look like. It's very hard to see, and originally wasn't, so I apologize about that. But this picture on the left-hand side is showing a patient who's either like standing or sitting in the high Fowler's position. And we can see how the fluid has accumulated in the base of the lung, also known as the costophrenic angle, right along that diaphragm here, okay? And then when the patient's laying down, it looks a little bit more evenly dispersed. It's called layering. We really don't want to see any white whatsoever in our lung. So we can see that in both pictures here. And again here, another great example of how the fluid collects in our lungs. We do not want to see any white patchy consolidations. On the left side, there's quite a bit of fluid, or I mean, in the left picture, there's quite a bit of fluid, it looks like, and that would be the right lung. And then again, on the right-sided picture, we would have more fluid accumulation in the right side of the lung as well. And this red outline is just showing you where we would notice that's what the kind of patchy consolidation is. And just some more pictures here. So this picture on the left side looks like the patient may be laying down because it's a little bit more evenly dispersed. And the picture on the right is showing an issue on the left side of the lung here. We have quite a bit of patchy consolidation on the left lung. So management and care, what can we do? Okay, we need to take that fluid off, right? So we need to relieve the fluid, and which also is going to help relieve the symptoms of what the patient's going through as well. It's always good to think about the underlying cause as well. But first, if we can eliminate some symptoms and get the patient a little bit more comfortable, that would be the best thing to do first. So thoracentesis is what can be done to help relieve the fluid out of the pleural space. So it's going to remove the fluid. It's going to hopefully help relieve symptoms, and actually can hopefully try to get down to the cause too, because this fluid can be tested and can help with diagnosis. So we're going to, aspirate the intrapleural fluid. And that is just a video below of what a thoracentesis looks like. Okay. And we can also do, for patients who have more chronic issues, we see this a lot in oncology patients or patients with cancer. They typically, chronically fill with fluid. So we're going to need a drain that's going to constantly help remove the fluid from the patient to keep their symptoms to a minimum, okay? So it's just a drain that is actually sutured in place, and the patient has it chronically. And it's typically placed on, right where kind of in the bottom of our ribs. And that catheter is placed right into the pleural space. Sometimes the patients, it's either once a day or twice a day, maybe 3 times a day, depending on how often the patient does fill with fluid. They just connect it to a gravity container, and it empties the fluid by gravity. Okay, and again, on the bottom here, it's showing you a video of what the Pleurex drain looks like and how it does empty the fluid. So again, going back to the basics, we do need to treat the underlying cause to hopefully help fix the pleural effusion, okay? So for example, if this was a heart failure issue and it's causing a pleural effusion, what would we need to do? What can we do to help treat the underlying cause of heart failure? Probably most likely, giving a diuretic. It's going to help take the pressure off the heart, take the workload off the heart and some fluid off. Maybe give the patient a sodium restriction. And with that, hopefully we would see a decrease in pleural effusion, okay? Again, we may need to tap the patient and do a thoracentesis and take off some fluid. Maybe not. So it's dependent on how much fluid is in the cavity as well. And going back to the Pleurex drains, malignant effusions, are a bit more difficult. They're a bit more complicated because it's chronic. So the patient's chronically filling with fluid. It continues to reoccur and reaccumulate pretty quickly. So that's why that Pleurex drain is very, very important. It keeps the patient a little bit more comfortable. So with thoracentesis, sometimes if the patient can tolerate it, typically they can sit on the side of the bed. They lean over a bedside table just to get kind of a good expansion of the lung at that point, and also it's better access for the provider when they're placing the thoracentesis needle. Sometimes it's done under x-ray or ultrasound. A lot of times I've seen this done at the bedside, okay? And so the skin is just cleansed with an antiseptic, and a local anesthetic is placed on the skin. Typically they use lidocaine for that. And the needle is inserted into the intercostal space and into the pleural space, and then the fluid's aspirated from there. And again, we can just be draining this, or we can do this for diagnostic reasons. And once completed, the needle is removed and then a dressing is placed over the site. We really should not be removing any more than 1 to 2 liters. 2 liters is kind of cutting it close. But we need to be careful when we're getting up into the liter range, and especially if we're getting up into the 2 liter range. If we have like a drastic removal of fluid, it causes like severe hypotension. The patient can actually have, increased pulmonary edema from too quick of a fluid being taken off. So we really need to be careful with that. A lot of times after thoracentesis, we do like to get a chest x-ray just to make sure that there wasn't any complications. Some complications of a thoracentesis is puncture of the lung. So we want to make sure that we didn't create a pneumothorax for any reason. And then chemical pleurodesis. This is very helpful in patients who may have lung abscesses, or they have empyema. So this chemical pleurodesis, again, it helps prevent reaccumulation of fluid into the pleural space. This is done by a chest tube does need to be placed for this procedure. And what happens is they place a chest tube, and then what they insert actually via the chest tube into the chest cavity is a chemical slurry. So it's really medication is instilled into the pleural space. So it's either talc, doxycycline, bleomycin. Those are the three most common medications that are instilled into the pleural space. After these medications are instilled, the chest tube's then clamped for 8 full hours. So a whole shift, the chest tube is clamped. And while the chest tube is clamped, the patient's going to be turned and repositioned at least every 2 hours, maybe every hour, just to make sure this medication kind of hits all areas of the pleural space. After the 8 hours, the chest tube is unclamped and it's attached back to the drainage system. And this is a typo. I apologize about this, but the chest tube is removed once drainage is less than 150 mLs per day. This says per hour on the slide. Just cross that off and put 150 mLs per day, okay? And we want to make sure that the patient does not have any air leaks. So for management and care continued, so if we're talking about more of like the smaller effusions, typically those are the transudative effusions. They're a little bit smaller, a little bit easier to control. A great example for a transudative small effusion would be heart failure. It's causing fluid back up into the pleural space due to the high hydrostatic pressure, right? So again, we may need diuretics, possibly a sodium restriction, to help decrease the fluid in the pleural space. Again, yes, we may need to tap the patient depending on how much fluid has accumulated in the pleural space since. But again, fixing the underlying cause is really important as well. And then the larger effusions are the exudative effusions. A great example for this type of effusion is cancer. And these are more chronic, okay? So yes, we'll need probably a drainage system, a thoracentesis. And if it's chronic, we can probably, the provider may want to insert a Pleurex catheter to have chronically for the patient so they continuously remove fluid on a daily basis. And then empyemas or large loculated effusions. These are more infective and inflammatory. So a great example for this is pneumonia can cause empyemas, and also TB is a great definitor that causes empyemas. Most likely we do need surgery. A lot of times empyemas are a little thick. Sometimes they can be drained, but we do need to keep in mind that sometimes they are a little bit too thick to drain, and that's why a VATS is more of the direction to go for this. And this video is just talking about what a VATS procedure is and how beneficial it is today, and how fast patients can recover from a VATS procedure. Um, And that is just another video. Okay, guys, so we're moving on to acute respiratory failure. So why does acute respiratory failure occur? And this is where an issue where gas exchange is impaired for some reason or another, okay? Where does our gas exchange become impaired? And that's most certainly in the alveoli. Yes, correct. So we're going to have an issue in our lungs with oxygenation and probably ventilation as well. So oxygenation is our perfusion, and ventilation is more of our mechanical part of our lung, okay? So in the alveoli, oxygenation and ventilation are both inadequate for some reason or another, and we're going to go over reasons why that can happen. So not enough oxygen is transferred to the blood, or not enough CO2 is removed from the lungs, okay? So when we're not having enough oxygen, that's an oxygenation and a perfusion problem. And if we're not having enough CO2 removal, that is a ventilation problem. So what happens to the patient? The patient becomes hypoxic and also hypercapnic. So think about that perfusion ventilation again, okay? So in perfusion, we're going to most certainly become hypoxic. And if we're having a ventilation issue, we're going to be hypercapnic as well, meaning we're holding on to CO2. So what is a good diagnostic tool to determine inadequate gas exchange? ABGs for sure. Very good. Okay, so moving on to different types of respiratory failure, and we kind of got a little good intro in the slide prior to this. So we have hypoxemic versus hypercapnic respiratory failure. So there's two different kinds, and really kind of what we were mentioning prior is that there's either an oxygenation or perfusion failure or a ventilation failure. There can be both, okay? So it can't, it just doesn't mean that there's one or the other. Patients can have both types going on at the same time. So hypoxemic, meaning that there's a perfusion issue, also known as an oxygenation failure. It means that on the ABG, their PO2 will read less than 60, even when they're receiving oxygen concentrations more than 60%. So there's some inadequate exchange of oxygen between the alveoli and the pulmonary capillaries, and we know that's where gas exchange occurs. You told me that in the previous slide, is in the alveoli. So we know that there's some issue here. Despite adequate supplemental oxygen, our PaO2 levels do not exceed 60. Okay. On the other side, we have more of a ventilation failure. So this is hypercapnic respiratory failure. So this is more of a mechanical issue. And this is when your ABG is going to read a PaCO2 of more than 50 or more. Also with the patient's going to be acidic with their pH less than 7.35. So there is insufficient CO2 removal for one reason or another, and we're going to talk about some of those reasons. And also, is the body able to compensate, right? So if there's no compensation, we are not able to hyperventilate, and we're holding on to CO2, right? So we're hypoventilating, meaning that our PaCO2 levels are going to rise, and we're going to become more acidic. So a little bit more pathophys here on acute respiratory failure. We're going to dive a little bit deeper into like the perfusion and ventilation issues. So we call it a mismatch. Okay, so I'm not sure if you remember VQ, VQ mismatch, V meaning ventilation, Q meaning perfusion or oxygenation. Okay, so if you're thinking of V, that's kind of more of the CO2 type of mechanical ventilation going on, and then Q is that poor oxygenation, that hypoxemia, poor perfusion. So there is a mismatch between ventilation and perfusion. Normal alveolar ventilation, V, and normal pulmonary blood flow or perfusion oxygenation, meaning Q, okay? Both of them are 4 to 6 liters per minute normally. okay? And we want a matching ratio, okay? So we want a ratio equaling like a 1-to-1. So if we have one that's off in any manner, we have some sort of mismatch. Like, for example, if there's like a 3-to-1 instead, we definitely have a mismatch. Or if there's a 1-to-3, there's definitely a mismatch. So our respiratory tract is failing for one reason or another. And again, it could be either ventilation, which again is the mechanics of the alveoli, or it could be perfusion, which is the quality of your oxygenation, meaning Q. Okay, so VQ, that's where VQ comes from, ventilation and perfusion. VQ mismatch. So in normal lungs, the volume of blood is perfusing the lungs and the amount of gas reaching the alveoli should be identical. And that's where we should be getting our normal 1-to-1 ratio match, okay? When there's not that 1-to-1 ratio, like we talked about, maybe like a 1-to-3 or a 3-to-1, that's where we have that VQ mismatch. So what conditions can cause a VQ mismatch? Most common are diseases that cause secretions in the airways or in the alveoli. That can be very, very common to cause a VQ mismatch. So I know we mentioned COPD, could be pneumonia, asthma, even pain. So we talked about pain being a big downfall, especially to our ventilation, right? So especially like, for example, rib fractures. If we're not going to be able to take in good deep breaths, we're going to have a VQ mismatch, especially if we're having pain, okay? Alveolar collapse is another example, also PEs. And then moving on to a little bit more pathophysiology, some more reasons why blood is not getting oxygenated in the alveoli. So shunting can occur. So a shunt occurs when blood exits the heart without the proper gas exchange, okay? Then we have anatomic. Anatomic is, like it states, more of an anatomical problem. The blood is passing through an anatomic channel in the heart, and it bypasses the lungs. So it doesn't even get to the lungs, it bypasses them. So a good example of an anatomical defect would be a ventricular septal defect. And we can see this a lot in infants or peds. And then intrapulmonary is where actually blood flows through the pulmonary capillaries without gas exchange. So it's skipping the alveoli. Okay, it's trying to get into the alveoli and it's trying to find that gas exchange, but it can't. So why do you think the blood is skipping the alveoli for one reason or another? Our alveoli are probably either collapsed, or they're filled with fluid, okay? A really good example of this is pneumonia, okay? And then gas exchange is severely impaired. The blood wants to get into the alveoli, but it's not due to fluid-filled alveoli. Sometimes alveoli could even be filled with secretions. So there's a blockage for some sort, depending on whether it's fluid or secretions. It's not letting the blood in and getting properly oxygenated through that gas exchange. So typically oxygen therapy alone is really not enough, or it's not effective enough to increase the oxygenation of the patients. Patients with shunts are a little bit more hypoxic than others. And they tend to be a little bit more hypoxic when it comes to that VQ mismatch. So they're going to have more of a problem with the perfusion type, or the Q of the VQ mismatch. These types of patients, especially with shunting going on, often need a mechanical ventilation. So again, with shunting, occurs when blood exits the heart without any gas exchange whatsoever. And then just a little bit more pathophys. So we're going to talk about diffusion limitation. And this is actually when the alveolar membrane, so it's just that little part outside of the alveolar. It's the outer membrane of the alveoli. It's actually becoming destroyed, fibrotic, or thickened. And because of that, we're going to have less compliance of the alveoli. Our alveoli are not going to expand to the proper amount. And because of that, we're going to have poor gas exchange, right? So gas exchange is compromised. So what conditions can cause the alveolar membrane to become really, really thick and almost fibrotic? Pulmonary fibrosis is a great example, cystic fibrosis, and what we're going to talk about in a little bit is ARDS, acute respiratory distress syndrome. A big part of ARDS is actually like kind of like hardening and decreased compliance of the alveoli. A classic sign of a diffusion limitation is hypoxemia. Especially it's present during activity and exercise, and it's not as much so during rest. So if we think about it, our alveoli cannot keep up with the quick blood flow going through, especially if we're having activity or exercise, and our blood's going to be going through quicker, right? Because we're exercising. So when that's happening, our alveoli that are destroyed, thickened, or fibrotic are not going to be able to keep up as quickly with that gas exchange. So we're going to see patients be very hypoxemic during activity and exercise. Again, this makes a lot of sense, but it occurs in conditions when cardiac output is increased. Another example is exercise. And then there is alveolar hypoventilation. So this is a decrease in ventilation. So this is our mechanical portion, right? So this is why we're holding on to PaCO2 or carbon dioxide. So there's a decrease in ventilation, results in increasing PaCO2 that we would see on our ABG. So this would be the hypercapnic respiratory failure portion and not the perfusion. And what can cause alveolar hypoventilation? It can be asthma, COPD. What's very common is neuromuscular conditions. For example, Guillain-Barré, MS, ALS, any central nervous system conditions. Even if you think about it like an overdose, any type of like opioid or drug overdose that's causing respiratory depression, that's another example of ventilation failure. It could be kyphoscoliosis even, where the patient can't fully expand their lungs due to a abnormality, and also restrictive lung diseases. So many of these conditions can happen together. It doesn't have to be just one. It doesn't have to be just shunting, or it doesn't have to be just intrapulmonary issues or diffusion limitations. A lot of times these can all happen together and be causing issues with gas exchange or impaired ventilation. Okay, so we are out of the pathophys. I know you're happy about that. So these are just splitting apart reasons or causes for hypoxemic versus hypercapnic failure. So if we're having more of a perfusion issue and more hypoxemic issue, we're going to run into acute respiratory distress syndrome would definitely be one of them. And if you remember, going back a slide or two, that would be the diffusion limitation issue, where your alveoli are getting very hardened and fibrotic, and it's causing impaired gas exchange. Hepatopulmonary syndrome, massive PEs can most certainly cause hypoxemic respiratory failure. Pneumonia, pulmonary artery lacerations, and also hemorrhaging. Toxic inhalation, smoke. We talked a lot about that with burns. Ventricular septal defects, and that would be more of an anatomical issue. Cardiogenic pulmonary edema, and then cardiogenic shock. And then on the other side, more of the ventilation mechanical issues would be asthma, COPD, cystic fibrosis. It could be brainstem injuries, spinal cord injuries, traumatic brain injuries. Anything neurological can most certainly depress our respirations. Sedative or opioid ODs, depressing respirations. Pain we talked about. So example, like a rib fracture, we're not going to have that adequate expanding and contracting of our lungs due to pain. So we're going to hold on to more CO2. Severe obesity, especially when the patient is more laying flat, they're not going to be able to expand their lungs as well due to just the pressure on their chest. Thoracic trauma, and again, more neuromuscular disorders, ALS, GBS, MS. Okay, these are all reasons why we would be holding on to more CO2. So consequences of hypoxemia, okay? So hypoxemia, it leads to, it's actually hypoxia, so kind of more of a simplified version where hypoxemia is just decreased oxygen and where hypoxia is actually the signs and symptoms of what hypoxemia is, okay? So it leads to hypoxia. So that's when the PaO2 reading on your ABG is going to fall enough to cause signs and symptoms of inadequate ventilation. So that's what hypoxemia leads to. What do our cells shift from? Okay, thinking of our cells. So they're shifting from aerobic to anaerobic. Okay, so thinking air is good, aerobic, we want aerobic, but we're unfortunately shifting to anaerobic. If you think of N, no air, poor oxygenation, if that will help you at all. Which metabolism uses more fuel? That would be anaerobic for sure. Okay, anaerobic uses more fuel, but unfortunately it produces less energy and it's less efficient. So we're switching to a metabolism that's going to take up more energy from our body, but it's going to give us less. Okay. And what is the waste product of anaerobic metabolism? And that would be lactic acid. And you guys are pretty familiar with that a little lactic acid by now. So what occurs with buildup of lactic acid? We get that acidosis, right? And in these cases, we're probably in that respiratory acidosis. And this is by the time where we're not compensating anymore, right? So when we get to the point of acidosis, we pretty much lose compensation. When we're during the compensation part, we're going to be more alkalotic. So what are we going to see when we have higher levels of lactic acid? A high venous lactate. So if that's untreated, if it's left untreated, and we continue to go progress into acute respiratory failure, and our levels of lactic acid continue to rise, that just leads to cell dysfunction and death if untreated. So signs and symptoms of acute respiratory failure, there's quite a bit of them. So our first and foremost, one of the first signs of hypoxemic respiratory failure is our neural function. Okay, so we're going to have a decreased level of consciousness, and we're going to have our altered mental status. This can lead to either restlessness, it can be agitation, the patient can be confused, they can even go the other way and be more somnolent or hard for the patient to even respond. The patient can become tachycardic, especially more so in the earlier stages if we're still trying to compensate a little bit. The patient may be tachycardic and also tachypnic, right? So if they're breathing a little bit more fast, we know that they're still trying to compensate a little bit, and it may still be in the earlier stages. Where if they go, more breathing less and hypoventilating, we know that we're losing our compensation. Our SpO2 is going to be, less than 90. At the beginning and earlier stages, we're going to be more hypertensive. And then more in the late stages where we're not compensating as well, we're going to run into hypotension, okay? Patient's going to be diaphoretic. They're working hard. We may see some nasal flaring or pursed lip breathing, and that is just a reaction of our body to try to get more oxygen in. Cyanosis is a early or late sign? Cyanosis is a late sign. We're going to see the patients increase work of breathing, okay? They're going to be very short of breath. We may see intercostal muscle retractions. And then digging a little bit more deeper for thinking about it, kind of like all the same things in relation to shock and what we talked about with shock, is we're going to have kind of more organ ischemia now. So if you think about it, our alveoli are either collapsed, they're filled with fluid, we're not getting that proper gas exchange through our lungs, and it's going out to the rest of our body. Do you think our GI tract is going to be oxygenated with the blood moving through? No, it didn't receive that gas exchange. So we're going to probably have some GI tissue ischemia for sure. That can lead to, a paralytic ileus, GI bleeding, ulcers. And then also the same thought with our renal system, right? So we're going to have impaired renal function, decreased urine output, edema, leading to acute kidney injury for sure. So these can happen, acute respiratory failure can happen very suddenly, or it can be gradual. So there's a very big difference between patients either happening from minutes or to hours. So it can be more acute, or it can, last a little bit longer and be more gradual and chronic, such as, maybe a few days. So a sudden decrease in PaO2 or a rapid rise in CO2 implies that there's a serious respiratory issue going on, and they're probably going to present with these clinical manifestations. And like I said, going back to our neurologic system, where our first sign of hypoxic respiratory failure is decreased level of consciousness and altered mental status, our brain is very, very sensitive to changes in oxygen and acid-base balances. So that's why it's the first one to feel that change in our body. Okay. And then, okay, so we're moving on to some diagnostics that could be helpful for acute respiratory failure. So this would be a chest x-ray is very beneficial. It can show us, if we have any underlying issues going on, like is there any atelectasis? Is there any pneumonia going on? Are they having some COPD? Can we see the fluid in the lungs? So it's very helpful to see any underlying processes that may be going on. Is there a pneumo? Is there, we can really visualize with this chest x-ray what may be the underlying condition. ABGs are so important. Okay, so we know that we're going to evaluate our oxygenation being the PaO2, and we're going to evaluate the ventilation, that being the PaCO2, and of course our acid, balances as well. Are they acidotic? Are they alkalotic? So ABGs are so important, and they're going to also help us with getting the patient better too, and getting them on the right oxygenation path to get them better. So vital signs, we know that that's important, especially along with the pulse ox, to get that that saturation level. CBCs are helpful. They can tell us if we have an increased white blood cell count. Is there an infection going on? Is there any abnormal hemoglobin, changes in our hemoglobin? BMP readings or CBPs. This can tell us if there's any electrolytes that may be off. 12 lead EKGs are important. Always good to rule out anything cardiac going on. Blood and sputum cultures, very helpful in diagnosing an infection. CT scanning if we want to get a little bit better picture of what's going on with our lung, if we want to rule out possibly a PE, and go a little bit deeper in our diagnostics. VQ scanning, very helpful. It's going to show us kind of where the mismatch is. It's going to show us if there's more of a ventilation mismatch or is there a perfusion mismatch. And this is like a radioactive isotope that does get injected into the patient. And we're going to see the line of where maybe the oxygenation is decreased, or where the blockage is, or maybe, is this happening in the alveoli, kind of where the problem may be occurring. We use this a lot too in PEs, for diagnostics of PEs as well. And tidal CO2 readings are very, very helpful. They show us the amount of CO2 that's being blown off from the patient. And really getting a little bit deeper into hemodynamic monitoring and more invasive lines would be central venous pressures or a central line or arterial line. And that can be very helpful for taking a lot of ABGs off the patient. We don't want to keep poking the patient if they are needing frequent ABGs. So an arterial line would be very helpful with that. So we're going to go through a quick assessment. Okay, so you have a patient that's in acute respiratory failure, and we're going to assess neuro first. So we're going to get down to the bottom of what's the underlying cause if we can, right? And we're going to try to fix that underlying cause, which is hopefully going to in turn fix their acute respiratory failure. And we're going to tailor that management strategies, based on this patient's specific needs. Okay. So severe acute respiratory failure patients will definitely be in the ICU setting. But these patients can be anywhere in the hospital for sure. And like I said, this can happen very, very suddenly, these symptoms, and we need to know what to do and act properly to help fix these patients. So neuro, we're going to see that increased confusion, right? And that's our first sign. Our brain is very sensitive. Our cerebral perfusion is the most sensitive to any changes going on with gas exchange in our bodies. So we can have increased somnolence, confusion, we can be delirious, we may see agitation and restlessness, okay? Cardiac. We'll probably see some tachycardia in the earlier stages while the patient's still compensating, and it can progress to bradycardia in the later stages. Same thing with blood pressure. So we'll see a little bit more hypertension in the beginning, and as we decompensate, we're going to be going and seeing more hypotension. The skin may appear pale, cool, clammy. We may have some peripheral edema going on. We want to look at palpate our peripheral pulses as well. In our pulmonary system, so we may see increased respiratory rate or tachypnea, and that's going to be more of the compensation phase, whereas when we're going to the decompensation phase, we're going to be more see hypoventilation. So we're going to be holding on to more CO2, and this is where we become acidotic. We're going to see increased work of breathing, accessory muscle use. We want to watch for pursed lip breathing or tripoding, intercostal retractions. Listen to the breath sounds. What do they sound like? Are there crackles? Is there rhonchi? Do we hear any breath movement in our lungs at all? What's the O2 sat of the patient? Is there any cyanosis going on, which we know that that's a late stage? How's their end-tidal CO2 level? So a lot that goes along with pulmonary for sure. And then GI, we know that, GI or renal, we're going to have that decreased gas exchange in our blood, meaning when our blood passes through our GI tract and our renal system, that blood's not going to be oxygenated too well, and that's going to have a big effect on these organs. So we may hear decreased bowel sounds, possible ileus. We may see some abdominal distension. We may see decreased urine output, concentrated urine. Acute kidney injury. So nursing, we want to provide that adequate oxygen therapy, okay? And we want to correct that hypoxemia the best that we can. So we're going to administer oxygen. We're going to hopefully start low if we can, start at the lowest level, and if we need to try titrate up, then that's what we need to do, okay? If we need to switch oxygenation methods, then we may need to switch oxygenation methods and therapies as well. It's always important to keep those COPD patients in mind, right? So these patients like to they can't really let off a lot of CO2. It's more of a ventilation problem. So if we're giving a lot of oxygen to these COPD patients, all they're going to keep doing is holding on to more CO2, and we're going to worsen their ventilation issues, and we're going to become acidotic very, very quickly. Okay, so always keep that in mind with COPD patients and what their baseline oxygen levels are and where they live. Sometimes these patients live maybe 88 to 90%, and that's their normal. So it's always important to know their normal before we really start pushing a lot of oxygen into those patients. We want to observe, the response to the oxygen therapy. How do we know the patient's getting better? We're going to see that, their altered mental status is going to get better, right? So if we think about it, if our cerebral perfusion is very sensitive and our brain is very sensitive, it's going to pick up on the better oxygenation as well. So we're going to be less confused, less agitated, less restless. We may not be as sleepy or somnolent. So those should be one of the first signs that we should see the patient kind of coming around with better oxygenation. We'll see a decreased work of breathing. We'll see our O2 sats get better. Our ABG should get better. The patient, hemodynamics will become more stable. And those are just a few examples of the patient getting better. Even they may pick up on urine output. We may hear bowel sounds again. And in class, I know we went over the selected devices of oxygen, so it's just good to review those and know the options that you have. We went through the nasal cannula, which would be your first option, and we can titrate up to 6 liters at the most on nasal cannula. Next is the simple face mask, especially if the patient's more of a mouth breather. Nasal cannula isn't very helpful for mouth breathers. So that's kind of a decision we have to make as nurses to change over to that simple face mask so the patient's getting, at least the adequate amount of oxygen that we want them to receive. We also talked about the oxidizer pendant. It's kind of the next step up from that nasal cannula. We can give a little bit more oxygen with that, like a 6 to 12 liter oxygen flow with our oxidizer pendants. And that's nice because in that pendant part, the oxygen harbors in that pendant, and when that patient takes in that deep breath, they get more FiO2 at that one point in time. Okay, so that's the whole point of that oxidizer pendant. We also talked about non-rebreathers. That's kind of more for the emergent situations and where they need more of 100% FiO2. So we pump that liter of flow all the way up to 15 liters when they're on that non-rebreather. And then we're going to get into more, we're going to talk about BiPAP, CPAP, and of course we're going to later get into mechanical ventilation. We also want to be careful of administering high FiO2 amounts in greater than 60% for more than 48 hours, okay? So that can increase the patient's risk for oxygen toxicity. So high amounts of prolonged FiO2 can cause damage to the alveoli and our alveolar capillary membrane. It can cause a lot of inflammation, okay? So this can cause the alveoli to collapse even more than they already are if they are already. They can lose structural support with high FiO2, and they can actually decrease their surfactant production, which we know surfactant helps with the structural support of our alveoli, and it keeps our alveoli open. So that's always something to keep in mind. If you're administering FiO2 in amounts greater than 60% for more than 2 days, it's really something to think about. And also mobilizing secretions, not only giving oxygen, but if we don't mobilize those secretions, oxygen's not going to be beneficial, right? Especially if those secretions are deep in our alveoli, it's not going to do anything, right? We're going to have blood that's going to try to get into our alveoli and oxygenate and get that gas exchange, but because it's so chock full with fluid and secretions, it's not going to happen, okay? So what ways can we mobilize secretions? Positioning. So lifting that head of the bed up. We want, if that patient's in severe respiratory distress, if they're having a lot of secretions, that high Fowler's position can be very helpful for the patient, and hopefully helps with draining of the secretions out of their lungs. Even getting that patient up to the recliner, it can really help maximize expansion of the lungs. So our lungs are always best upright, right? Not laying down. It's going to just put more pressure on your alveoli. So if we get these patients upright, get them out into the recliner, it's really going to help with drainage of our secretions. Slide line can be pretty effective. So talking about that good lung down, right? So we want that bad lung or the affected lung up, and that lung is going to, with that lung being up on that sideline position, it's going to help with the secretions draining out from that lung. We typically use this sideline position as well when we're, if a respiratory therapist will be doing percussion or vibration to help get secretions out. I know we do have beds, and we typically have our percussion vibration pulmonary beds now, and we don't typically see handheld maneuvers much more. But if it were to happen, we would want that patient to be side lying, and we'd be percussing and vibrating over that affected lung just to help with postural drainage. Effective coughing and deep breathing, very important, if the patient can do so. So sometimes we get to that level of acute respiratory failure where the patient is so weak they even lose their ability to give a good deep breath and cough. So it's something to think about as nurses. Can the patient do it? How can we help the patient cough and deep breathe? If they can't, what can we do to help them? Okay. We talked about augmented coughing, also known as quad coughing. So that's when the provider actually puts his hands on the anterior aspect of the base of the lungs, and he has the patient take a deep breath, and on expiration, these hands move up in an upward fashion on the lungs, and we're going to hopefully induce coughing and get these secretions up. We talked a little bit about chest physiotherapy, so that can be another great example of how to mobilize secretions. Suctioning. So we can suction, we can use a Yankauer suction. That can be very helpful for our upper airway and mouth secretions. But what's really detrimental is the secretions that are deep in our lungs, especially our alveoli. So if our patient can't get that up with a good cough, sometimes we really need to do a deep suction, okay? So that is with a catheter like method, and that catheter is placed, down into the nose of the patient and deep into the lung using suction. So that can better the patient in getting the secretions up if they can't. Oral hydration or IV hydration is very useful as well. It's great to thin the secretions if we can. It makes it a little bit easier to get up instead of thick mucoid secretions that are kind of stuck down deep into the lung. And then humidification. Humidification of oxygen can also help with getting the secretions up. Aerosolization, saline, also early mobilization if the patient can tolerate it, if they can get up and walk and mobilize. And I urge you to continually kind of review oxygen delivery methods. It's just good to know all the different things that you can do as a nurse to help with oxygenation for our patients. And this was just a slide on that quad coughing. It's a picture of what the hands look like at the beginning of inspiration, and then on expiration, these hands would move up in the upward fashion in the lungs to try to help get the secretions up and maybe get the patient to cough a little bit as well. So positive pressure ventilation. So we're kind of moving on to more oxygen support, a little bit more higher level of oxygen support. So this is non-invasive, NIPPV, non-invasive positive pressure ventilation. And this is when it's either a BiPAP or CPAP, and it's a mask, and it's placed tightly over the patient's nose and mouth. Some masks are different. Some masks are full face, and then some masks just require the nose and the mouth, which is pretty much what we have at Berkshire Medical Center. Okay, we don't have the full face masks. So when the patient breathes in a breath spontaneously, that machine, the positive pressure ventilation, is actually delivered into the patient on that expiration. So it senses that inspiration, and it administers a percentage of FiO2. So there's going to be a setting on the machine that will give the patient a certain amount of FiO2 that either the respiratory therapist or provider recommends for the patient to receive. We definitely will use this for patients who have had, increase work of breathing to hopefully decrease their work of breathing and make them more comfortable. And we're hoping to use this in avoiding the need for an endotracheal intubation. So this is always a good thing to try first before we move on to intubation. It's a more non-invasive maneuver that can hopefully help the patient before they get too decompensated. Positive pressure ventilation is most useful in patients who have chest wall possible traumas of the chest wall or even neuromuscular problems. So those two issues are the most beneficial for our non-invasive positive pressure ventilation. COPD patients, it's very beneficial also to our COPD patients. It can help these patients breathe off a lot of CO2 that they have on board without mechanical ventilation. These are also for patients who really do not want to be intubated at all. That is not their wish, but they do want some degree of ventilator support. So a BiPAP or CPAP would work well for these patients at all. It is not appropriate, so things that aren't appropriate for patients for non-invasive positive pressure ventilation is patients who have decreased level of consciousness. Are they somnolent? These patients need to actually be able to be well enough to take a good deep breath, to take a good breath in, okay? But if we're having more decreased level of consciousness and somnolence, they're not going to be able to do that. So that's something to think about as a nurse. Do they need even higher requirements of oxygenation? We'd probably have to move on to mechanical ventilation from there. If the patient has any facial trauma, that's something to keep in mind, especially with the mask on their face. If their hemodynamics are unstable, BiPAP or CPAP is not recommended, or if they're having large amounts of secretion. So think about that. If we're pushing secretions deep down into the lungs, that's not going to be any more beneficial for the patient. We're actually making them worse off, and we're even possibly causing an aspiration issue as well. So a little bit deeper into our positive pressure ventilation, we have continuous positive airway pressure, also known as CPAP. So CPAP delivers a one level of constant pressure to the patient's airway during inspiration and expiration. And then on the other hand, there's also BiPAP, which is bilevel positive airway pressure. So this delivers two levels of positive pressure, one on inspiration and then the other on expiration. So it's two levels of pressure. The most common device that we use is BiPAP, especially for acute respiratory failure or COPD. We do typically go towards the BiPAP in the hospital. So this provides oxygen therapy. Some BiPAPs do deliver humidification. It helps decrease the work of breathing of our patients and hopefully reduces respiratory muscle fatigue as well. That positive pressure can hopefully open up those collapsed alveoli a little bit more. I know mechanical ventilation will most certainly do that with the PEEP levels, but hopefully BiPAP can offer that to the patient as well in the beginning stages if we can prevent them going to the mechanical ventilation portion. BiPAPs help decrease shunting. Again, it opens up the alveoli, so there's no bypass of the alveoli. And again, if we see that the patient is becoming more fatigued, if their work of breathing is increased even on the BiPAP, we're probably going to have to move to mechanical ventilation. And again, the patient must be awake, most likely alert, and have some sort of hemodynamic stability. And then that's just a good picture of kind of what the masks we use at BMC. And this is just a longer video showing you how they attach a BiPAP. In the video is a BiPAP that is a full face mask covering the eyes as well. And then just some medications to think about for acute respiratory failure. We do want to reduce airway inflammation and bronchospasms. And two medications that can help with that are corticosteroids. So IV methylprednisolone or Solu-Medrol is very, very useful. That's given IV push for these patients to help with inflammation and also strengthening of our lungs. And also bronchodilators can help with bronchospasm, and albuterol is very common for that. Also, if there's pulmonary congestion going on, if that's the underlying cause, we can relieve pulmonary congestion, of course, with IV diuretics. Our most popular one being furosemide or Lasix. That can be given IV push typically. If it's really severe, it can be given by a drip. Morphine actually has it can also help relieve pulmonary congestion as well. It can take off the demand of oxygen or more oxygen consumption, so it relieves the patient's work of breathing. So it can do two. So it can actually, help with a little bit of diuresing, and it also takes off the demand for oxygen consumption, and it gives the patients a little break, and it decreases our work of breathing. Nitroglycerin actually does the same thing. We don't tend to see this used a lot at all, but it kind of has that same qualities as morphine may for the patient. Treating infections. Okay, that's a big one. So if there's an underlying infection going on, we most certainly want to give those, antibiotics depending on what they come back for a microorganism. So that depends on our cultures. And then reducing anxiety and pain is actually a big one, more than you think. So if you think about it, if our patients are very, very anxious and restless, that's going to increase their work of breathing and their demand for oxygen consumption. So we want to decrease any other demands that is not necessary for the patient to be dealing with. So if we can take off a little bit of anxiety for the patient, such as Ativan or lorazepam or Versed or midazolam, it would be very, very beneficial to the patient. Opioids, so we talked about pain and providing that proper expansion for breaths, especially if we're needing to get rid of the CO2. We want to provide pain medication so the patient can properly ventilate, okay, and decreases their pain. So fentanyl or morphine can be very beneficial for that. And also, like I talked about, morphine has that characteristic of taking off some workload of O2 consumption as well, okay? And that is acute respiratory failure. And we're going to move on to acute respiratory distress syndrome. Okay, so this is severe. So we're getting into the more severe states of any type of respiratory distress. It's a sudden and very progressive form of acute respiratory failure. And like we talked about, this is when our alveolar membranes and our alveoli are starting actually to become fibrosed and hardened, and they're going to lose their flexibility. Okay. They become damaged. The most common cause of ARDS that we typically see is from sepsis. And really, we see these patients a lot in the ICU. Next to septic shock, this is the most common admission to the ICU. So there are two types of ARDS, well, really lung injury involving ARDS or causing ARDS, is there's a direct or indirect injury, okay? So direct, it's kind of just like it states, it comes in contact with the lung itself. So it's some pathogen that comes into contact with the tissue of the lung, and it initiates that inflammatory response. So a great example that we can use with that is actually like aspirated gastric contents or even aspirated feedings. That pathogen comes in contact with the lung, and that will create an inflammatory response and further an infection. And that's directly in contact with the tissue. So that can make sense with that type of injury, right? Direct injury. Can cause a bacterial or viral pneumonia. So we typically see this a lot with aspiration issues. Also leads to sepsis, of course. And then in indirect injuries is actually a problem from somewhere else in the body that is widespread, and then it kind of harbors in our lungs, okay? Why do you think it harbors in our lungs, bacteria? It's a favorable environment. It's dark, it's moist, it's great for growing bacteria, and that's where our bacteria likes to harbor, especially if it's more of an indirect injury. So this is most common with gram-negative sepsis. If there's a gram-negative microorganism, it's very common with indirect injuries. If a patient's had severe massive trauma, okay, causing widespread inflammation. Severe traumatic brain injuries can cause widespread inflammation. Shock states. A great example is a bowel obstruction with perforation. That bacteria can harbor and go right into our lungs. So there's 3 phases of ARDS, okay? So the first phase that we're going to talk about is the injury phase or the exudative phase. And this phase lasts for about 24 to 72 hours. So this is more of the acute phase. And this starts post initial insult, either being a direct or indirect injury. And again, that's 24 to 72 hours after that insult. And this lasts about 7 days. Okay. So what happens is we have huge engorgement and inflammation in our interstitial space, leading to interstitial edema. So we're filling up with fluid, and of course that fluid's going to cross over that alveolar membrane, right? And if we have fluid crossing over into our alveolar membranes, that means the alveoli are going to be weighted down with fluid as well, okay? So these alveoli are either going to collapse, be weighted down with fluid, and one or the other. So once that happens, do you think we're going to have good gas exchange? Not at all. So we're going to have a VQ mismatch, right? So our perfusion is going to be off, and most likely our ventilation is going to be off as well. Our alveoli are filling with fluid, and that blood flow through our alveoli is not going to catch up, and it's not going to gain on that gas exchange. So our alveolar cells are now damaged, and we're going to have that increase in fluid and protein accumulation. And unfortunately, that leads to that decreased surfactant production. That surfactant keeps our alveoli open, and it brings them structure. Without the surfactant, they're going to be collapsed. This leads to widespread atelectasis. And why do you think that? Yeah, if our alveoli are weighted down with fluid or collapsed, that can most certainly cause a partial collapsed lung as well. So that's something to think about. Something that can happen to our patients in ARDS as well. So we know that because of poor gas exchange, our blood and our capillaries are not going to be oxygenated. And that leads to more like necrotic cells. So we're going to have tissue and cells that are dying because of poor gas exchange. So what this is creating, it's called a hyaline membrane. So this is where we're going to talk about that membrane being fibrosed, and this is the reason why. So it's due to that decreased gas exchange, and we're going to have high levels of fibrosis. And that hyaline membrane lines the inside of each alveoli, and unfortunately that's going to become severely fibrosed, and they're going to become stiff and rigid. So we're going to have severe gas exchange, impaired gas exchange, severe VQ mismatch. We're going to have shunting going on, decreased lung compliance. And this is actually a great deal of what we're going to call refractory hypoxemia. It's very important for you to remember the refractory hypoxemia. So if you think about it, our patient's O2 sat is going to be low, most likely, because our alveoli are fluid filled or collapsed, one or the other or both. So we're going to go down on O2 sat. So most likely our thought is, okay, we need to give oxygen to the patient, right? But if we're going to have fibrosed, non-compliant, decreased flexibility in our alveoli, they're going to be hard and stiff. Do you think that oxygenation is going to help instill into these alveoli at all? Not at all. So to get any proper gas exchange, these alveoli need to be opened up, secretions need to be removed, fluid needs to be removed. So we're really not doing much for the patient by just giving them oxygen. And that's what's called refractory hypoxemia. So despite receiving the higher levels of oxygen, the patient is going to continue to deteriorate because the oxygen is not going to get into the alveoli, and it's not going to create that gas exchange that we want to be happening. So our lungs have really become stiff due to the decreased surfactant. We have pulmonary edema, we have fluid-filled collapsed alveoli, and now we have this hyaline membrane that's causing a fibrous lining. So it totally reduces our lung compliance, and no matter how much oxygen you give this patient, they're going to continue to get worse. And that's what refractory hypoxemia is, okay? And it's very important for you to know that. So these stages only get worse. The next stage of ARDS is the reparative or proliferative phase. And this begins 1 to 2 weeks after the initial injury. So the first phase is about 7 days. And then now the second phase is about beginning at the first week and lasting about 2 weeks out from the lung injury, that being either direct or indirect, okay? And our inflammatory response is only continuing. It's only getting worse. So if you think about it, if we're having increased inflammation, and if we've had this decreased gas exchange for this long, do you think our fibrosis is going to get better or worse? That's going to get worse. So if we're still having that necrotic tissue forming in our alveoli and on our hyaline membrane, we're going to continue to see more non-compliant alveoli, non-compliant lungs. Our alveoli are continued to be weighted down or totally collapsed in general. This is going to continue with our increased pulmonary vascular resistance. We can even develop a pulmonary hypertension by this point. It's just due to the increased inflammation occurring and our cell destruction. It's really destructing our whole vasculature of our lungs, and that's what's going on. So we have continued decreased lung compliance. We're going to continue to have fibrotic alveoli. Our hypoxemia is going to worsen. We're going to continue to have that thickened hyaline membrane, continuation of that VQ mismatch. We see a completion of this phase when our lungs have been completely replaced by fibrous tissue, and that's what we're going to talk about in the third stage. Hopefully we can get patients better by this stage. Will they have a little bit of residual injury to their lungs lifelong? Most likely, especially if we have fibrosis going on in our lungs. We can't really fix too much of scar tissue and fibrosis, right? So that's going to be something that we're going to, on discharge, once the patient makes it out of this phase, we're really going to have to, make sure that they see pulmonary medicine quite frequently to continue to recover. And then moving on to the third phase, this is the fibrotic or fibroproliferative phase. And this is just more complete progression of ARDS. Patients do enter this stage. Can they get better from this stage? Yes, I have seen patients get better from this phase. It's very hard. We do see a high mortality rate once they enter phases 2 and 3, but a recovery can happen. So not all patients who develop ARDS enter the fibrotic stage, and hopefully they recover from there. But for patients who do not fully recover, their lungs actually become completely remodeled by this fibrous scar tissue. And we have diffuse scarring, we have interstitial fibrosis, alveolar fibrosis, and that's just very, very poor lung compliance in general. The lungs are become hardened, they're not flexible at all. And we have just very poor oxygenation and ventilation. Okay, so signs and symptoms of ARDS, they can be pretty similar to acute respiratory failure. And initial presentation may be kind of subtle, and especially like that initial injury phase. And that phase, as we know, that initial phase can last up to 7 days. But at initial injury and even up to like the 72-hour mark, these symptoms may appear more subtle, and then as we worsen and get onto more and more days, we'll see these symptoms get worse. Okay, so we'll see shortness of breath and dyspnea, and it can be, like I said, mild at the beginning, and then it can worsen day by day. Tachypnea, we know that that's kind of more of like in the initial phases, and as we decompensate, we're going to see more hypoventilation than anything, and that's where we're going to be holding onto CO2. We can see a cough. Think about this neurologically as well. So remember, our cerebral blood flow in our brain is very, very sensitive to any gas exchange changes that are going on in our body. So again, we would see that level of consciousness change, the alertness decrease, the increased somnolence, agitation, restlessness. We'll see increased work of breathing, possible intercostal retractions, as well as pursed lip breathing, nasal flaring, possibly tripoding. Tachycardia, again, at the beginning stages, yes. And as we decompensate, we're going to see more bradycardia. Diaphoretic, we talked about the neurological change as hypoxemia progresses, and we know that the change in our neurostatus is one of the first signs that we see. And we know that cyanosis is also a later stage, okay? As these symptoms get worse and more profound, and the patient is more in distress, this is when we can typically, they may need mechanical ventilation. If we can pick this up more in the earlier stages and treat the patient as early on as we can, we'll hopefully not develop into the later 2 stages of ARDS. So as nurses, what we can kind of do and help with diagnostics is for lung auscultation, especially in ARDS, we're going to hear more crackles than anything. So in the first few days, we may hear more fine scattered crackles, and that can progress on to diffuse coarse crackles in the later stages. ABGs. So at the beginning, it may be more mild, especially as we're compensating. We're going to see more hyperventilation where the patient's going to be more in a respiratory alkalosis. And as the patient progresses to severe hypoxemia and even severe ventilation issues, we're going to see hypercapnia. We're going to be holding on to more CO2. Patient's going to be hypoventilating, and we're going to be entering respiratory acidosis. So that's more of a later stage readings in our ABGs. And then chest x-rays. So at the beginning, we may see more normal or minimal diffuse scattered infiltrates. And as the stages progress, that can extend into, more bilateral, more interstitial infiltrates, alveolar infiltrates, kind of deep in the lung. And this is kind of when we see that complete whiteout, sometimes of both sides of the lung. There's not much recognizable air spaces whatsoever. And then we have continued diagnostics here. So again, we talked about that chest x-ray and what we can see from mild to severe as the stages progress. We talked about ABGs and what we would see in the readings as, the patient does decompensate more. Always taking vital signs, getting that pulse ox, CBCs, very similar to kind of acute respiratory failure. We would see that increased white blood cell count, looking for an infection, any changes in hemoglobin. For that BMP or CBP, we would monitor more for changes in electrolytes, always ruling out anything cardiac with that 12 lead EKG. Blood and sputum cultures, we want to make sure that there's no underlying infection going on. CT scanning if we want a little bit better picture, okay, to pick up of what's going on. VQ scanning, like we talked about with that injection of the radioisotope. We can see where that mismatch, what's going on with that mismatch. Is it more of a perfusion? Is it more of a ventilation? Is it both? End-tidal CO2 readings, seeing how much carbon dioxide is being blown off, and also that more invasive lines for the hemodynamic monitoring, central line placement, monitoring the CVPs, and arterial lines, especially if they need continued ABG readings. And then we're going to move on to a little bit more complications of ARDS. We haven't got into ventilators yet, but I just want to introduce you to VAPs, ventilator-associated pneumonias. So this is, a possibility of introducing bacteria into the airways by one mean or another, and it could be several reasons why there may be bacteria introduced into the airway. It could be for prolonged mechanical ventilation, also possible aspiration, either during intubation or while the patient is mechanically ventilated as well. So we need to keep in mind of the ventilator bundle, and we're going to get a little bit more into that as we talk about the vents. But hand hygiene is first and foremost. We know that's the most important factor in nursing for any type of, infection and preventing infections. Elevating that head of the bed at least 30 to 45 degrees. It's going to really hopefully decrease the risk of aspiration of any gastric contents, especially if the patient does have enteral feedings going on. We want to really make sure that head of the bed is up and any gastric contents or feeds are not going back into the lung. Really daily assessment of that readiness to extubate is extremely important. We typically in the mornings on the ICU do that sedation vacation where the patient comes down a little bit off their sedation. They awaken a little bit, and we can see how they can tolerate, if they're getting a little bit more alert to possibly tolerating being on a spontaneous breathing trial. Are they not ready yet? So doing that assessment every morning is going to kind of help get them off that ventilator. And we know prolonged mechanical ventilation increases our risk for infection. That Q2 hour oral care is extremely important, and that's with the use of chlorhexidine. We just use a toothette and we clean the inside of the patient's mouth and tongue, kind of the back of the throat if we can get there, with that chlorhexidine wash. It really, really helps prevent the bacteria of inside the mouth and going into the respiratory tract. Also, what's important too is that frequent suctioning as a patient tolerates, especially if the patient has a little bit more secretions than usual. We know that a lot of secretions can harbor bacteria, so either suctioning out the patient's mouth if they have huge oral secretions, or getting deeper using that mechanical vent deep suction, getting the secretions out from deep in the lungs is very beneficial to the patient. Next, we're going to talk a little bit about barotrauma. This happens when our fragile alveoli become overdistended with excess pressure from the ventilation. Okay, so whether that being by the FiO2 or the PEEP itself, we really need to keep that in mind and be careful of the pressures that are going into our patient, especially for patients of ARDS, because we already know that alveoli are so fragile as it is. They're fibrosed, they are non-compliant, so that puts the alveoli at a greater opportunity for them to rupture, or the air will escape from our alveoli in general. This leads to, barotrauma can lead to a pneumothorax, interstitial emphysema, and also a tension pneumo. Stress ulcers can form. So think about the blood and how it's being directed to the GI tract. Is our blood oxygenated? No, not at all. It's not well oxygenated at all. So we're going to have a little bit of necrosis going on in our GI tract, and that's going to affect, our bowel sounds. We're going to have hypoactive to absent bowel sounds. We're going to possibly have an issue with GI bleeding, and like this says, stress ulcers. Okay. So to correct this, it's very important to correct our hemodynamics first and make sure that we have the best cardiac output that we have, to help initiate a little bit better blood flow to our organs. PPIs such as protonics, we typically give an IV push protonics to patients, that can help coat the belly. Also, mucosal protecting drugs such as Carafate, the other word for that is sucrafate. That's typically given in a liquid form. And then early initiation of enteral feedings is super important to help coat the belly, and it helps prevent mucosal damage. We know that patients who suffer from immobility, or if they have a complication causing them to be immobile, that they're always at that high risk for blood clots. So patients with ARDS, they're predisposed to DVTs or PEs, and that's just something that we need to be aware of as nurses, and we need to make sure that that they're on that sub-Q heparin or Lovenox as well, as long as that's okay with the patient and they're not having increased risk for bleeding. Make sure that their SCD boots are on, making sure if they can ambulate or at all that we're trying to get them up and moving as much as we can. If not, we're turning and repositioning and doing range of motion with them at least every 2 hours. And then acute kidney injury. Goes back to our blood flow and our decreased gas exchange, right? So we're getting that decreased gas exchange blood into our organs. And so that's going to cause acute injury, decreased urine output. This can also occur due to hypotension as well. So again, making sure that we fix those hemodynamics the best that we can to have that better cardiac output. Also watching out for nephrotoxic drugs. That can be certain antibiotics. That can be Tylenol. We need that strict monitoring of INOs, and that's why those Foley catheters come important, just to make sure that we're having the best output that we can. Always monitoring the labs such as BUN and creatinine, and making sure the kidney levels are not rising. And possibly I've had patients, a lot of ARDS patients, who have needed temporary dialysis, just to keep that the kidneys functioning while the patient's recovering. So just some more complications of ARDS. We could have decreased cardiac output, and that kind of goes along with hemodynamics being unstable, our blood pressure decreasing, and the need for vasopressors. So that's kind of all intertwined there. We can run into a risk of dysrhythmias. We can have, neurologic dysfunction, like we talked about how sensitive our brain and cerebral blood flow is. So we'd have the delirium, somnolence, agitation, confusion. Patients also can run into PTSD, especially with being on the ICU. Much research has been done on patients who've been long-term on vents or have been long-term in the ICU in general. And they tend to need, frequent counseling. They talk about, a lot, they tend to have nightmares of what has gone on in the ICU. So that is a really important factor that needs to be taken care of. Paralytic ileus, we know these issues with the GI tract and the decreased gas exchange in our blood that goes to our GI tract. So that also causes stress ulcers and GI bleeding. We can have issues with DIC, disseminated intravascular coagulation, DVTs, PE, like we talked about, acute kidney injury. We can have CAUTIs, catheter-related associated infections, and also central line infections, also known as CLAPSIs, and sepsis in general. Okay, guys, so just like an acute respiratory failure, let's go through an assessment for our patient with ARDS. So you're a nurse and your patient has developed ARDS. What are we going to do as an assessment? Okay, what are we going to look for in our systems, in our body? Sometimes ARDS tends to be a little bit more emergent, and these patients sometimes need an airway right away. So it's great to get that thorough history if we can, but if not, we know most importantly the patient needs an airway to intubate, ventilate, get any hemodynamic monitoring lines in our patient, such as like our CVP, A line, stuff like that. That's most important first, and then we can go from there. So for neurologically, it's very, very similar to ARF, and we know that our brain is most sensitive to any gas exchange changes that are going on. So we know we're going to have that increased confusion, somnolence, delirium, agitation, restlessness, all things to look out for neurologically. Cardiac-wise, we know in our more compensation level to our decompensation level the differences, right? So tachycardia early on, bradycardia progresses to our later stages, hypertension early on, progressing to hypotension in our later stages. Always looking at the patient's color of their skin. Is it cool, pale, red, pink? What's it feel like? Is it clammy? Are they diaphoretic? Are they having any peripheral edema? How are their peripheral pulses? Pulmonary wise, the patient may be tachypnic at the beginning and later progress to more hypoventilation, where they'll be more acidotic at that stage. We want to watch for increased work of breathing, accessory muscle use, pursed lip breathing, intercostal retractions. What's their breath sound like? So in the earlier stages, we know that we may hear more fine crackles, and then the later stages, it may be more coarse crackles. What's their O2 sat like? Do they have an end-tidal CO2 monitor Are they experiencing any cyanosis? And we know that that's a later stage. And then GI, GU, we know that we're going to be decreased in both just due to the poor gas exchange. So we'll have probably those decreased or absent bowel sounds, a possible ileus, maybe abdominal distension, decreased urine output, acute kidney injury. And continued with nursing. So we really want to keep an eye on that oxygen, right? We need to oxygenate the patient the best that we can. So keeping that PA2 level as best as we can to the normal limits on the ABG. And that's what we're fighting to strive, is to get to that normal limit range, depending on what therapeutic measures that we need to initiate on the patient. Keeping that SaO2 greater than 90%. Providing that adequate lung ventilation to keep that pH level as normal as we can. You know, if they're holding on to more CO2, how can we get the patient to blow off the CO2 to get that pH level a little bit more normal? So we're constantly monitoring ABGs, okay? You know, and these patients are monitored and cared for in the ICU. Their course is so complex and unpredictable. This is where they need to be monitored. They need that continuous bedside monitoring, that invasive monitoring, A-line, CVP for central venous pressures, possible IV fluid administration. I mean, ARDS patients, we do try to keep them more on the dry side. It's just important to keep that good balance, especially if they are experiencing infection or that septic shock going on. Yes, they probably do need some fluids, but maintaining that balance the best that we can, because we don't want to overexert them with fluid and cause continued damage to our alveoli. Patients will most likely be mechanically vented. They're typically mechanically vented for multiple days. This is a severe and long process. ARDS is not a quick recovery. It takes some time to recover, and the lungs need complete recovery. We need to take all workload off the lungs, which is why mechanical ventilation is so important. Also, analgesia, giving the patient pain medications, especially if the patient is going to be mechanically ventilated, it's going to be uncomfortable. So we do need to provide some pain medication, that being fentanyl, Dilaudid, morphine, whatever the provider suggests for the pain medication. Sedation, very important. Again, if the patient is going to be mechanically ventilated, we need to sedate the patient. Typically with ARDS patients, we see them really fight the vent a lot. They almost feel like they're drowning. Okay, that's what these patients feel like. They cannot get a breath. And so when they feel like this, they're going to continuously fight the vent. So we try to keep these ARDS patients down as sedated as possible. We try to keep them as sedate as we can. Again, we don't want them fighting against anything. We need their lungs to relax, and we need their whole bodies to be relaxed to be able to recover to the best that they can. So that would be, Versed, propofol, Precedex is kind of newer, ketamine. Those are all examples of sedations. And sometimes even patients with ARDS, they fight so much, we can't really properly sedate them. Sometimes they do need a paralytic on board as well. Some good examples of those are vecuronium, Nimbex. Those are the two most common that we see used for paralytics. We just don't want the patient to be asynchronous with the vent. We want the vent working for them. We don't want them fighting against it. It's not going to benefit the patient. It's only going to make their lungs worse. So we need that really good balance of sedation and ventilation, okay? Always identifying and treating that underlying cause to hopefully get this patient better as quick as we can. Like I said, invasive line, CVP, and A-line monitoring. Nutrition therapy is always very important. It can cut down on our stress ulcers, GI bleeding, and it really coats the belly. We know VTE prophylaxis is important. VAP prophylaxis we know is very important. And these patients tend to be on vasopressive drugs because they are hemodynamically unstable. We always need a pain medication with a paralytic. It's kind of like, they may appear asleep and may appear pain-free because they're not going to be able to tell you if they're having pain, but inside it's almost like they're trapped in their body. They may be having pain. So it's always very important to make sure that you initiate a pain medication with a paralytic. Providers should know that, but it's a very important nursing knowledge as well. Let's see. That's good. And this is just example pictures. If a patient were to be on a paralytic, we do need to monitor them a little bit more closely. The picture on the top left is called a train of four. So it's just kind of electrical conduction that's going to show us how many twitches on the finger the patient is going to have. So it gives us that baseline of their neural capacity and their response to the electrical conduction, even though they are paralyzed. So it will initiate a few twitches. Typically, it's the pinky finger, and we're going to monitor how many twitches that the patient has. If they divert from the number, it means that they're changing in some level of sedation. So we do need to check that train of four at least every hour if they are on a paralytic. The picture on the bottom right is called a SEDline, SEDLINE, and these are electrodes. They're placed on the forehead of the patient, and they monitor that deep neurological sedation, making sure that the patient is at an adequate level of sedate. And so that's just another monitor. We keep both of these monitors on patients that are paralyzed. We, of course, want to initiate oxygen administration and do the best that we can with that. So correcting their hypoxemia, and of course, we're going to be watching their ABGs. Initially, we may try to use like a high flow oxygen system. So this delivers high concentrations of oxygen to the patient. High flow is only used for example, in Berkshire Medical Center. It's used in our PCU and in ICU. It's only temporary because it is instilling high flow oxygen into the patient's lungs. First of all, if they are having refractory hypoxemia and we're giving high levels of FiO2, is that doing anything for the patient? First of all, no. Hopefully this high flow may open up the alveoli a little bit, but it might not be enough to the point where they may experience gas exchange. So we need to be careful with that and monitor their PaO2 very closely. If the high flow does fail, we do need to move on to mechanical ventilation from there. We need to concentrate more on the collapsed alveoli more than anything because that's what's going to help with oxygenation and gas exchange. So we need to open up the alveoli first, and that's where mechanical ventilation becomes extremely important because we need to use that PEEP setting on the vent to maintain the functionality of the alveoli. So that'll help them open up. That'll create air, movement for gas exchange, for blood to flow through the alveoli and get that proper gas exchange for the body. And this video below is just showing you what a high flow machine looks like. It's really like a intense nasal cannula that's hooked up to a machine that is providing, it can provide up to 100% FiO2 and also 15 liters at the same time. So it's giving that the most oxygen the machine can. And it can be set lower, but it can go to the highest of 100% FiO2 and 15 liters of oxygen. Okay, guys, next we're going to talk about the prone position. This is highly beneficial to patients with ARDS. And typically, if we think about ARDS patients, we think about the therapeutic technique of proning. It's kind of, it goes with one another. So really think about your alveoli. They're fluid filled, they're collapsed. There's not a lot of flexibility at all in them. So initially fluid moves freely in the lungs. That's the beginning stages. And really gravity takes over and fluid is going to begin to pool, right? They're going to pool in our dependent positions in our lungs. And that's where the most of our fluid falls, is right in our alveoli. And that's why they become fluid filled. So if you think about it, when a patient is supine, they're laying on their back. Also, what's putting pressure on our lungs and our alveoli is actually our heart and our mediastinal contents. That actually places a huge extra pressure on our lungs. So in the supine position, it is not beneficial for ARDS patients at all. And sometimes it even predisposes ARDS patients to even develop an atelectasis. So proning is very, very useful in helping secretions drain and fluid drain right out of the alveoli. It's offloading your alveoli and taking a lot of pressure off of them. It's also taking that pressure from the heart and the mediastinum off of your lungs and alveoli as well. And that's just going to help offload your lungs and your alveoli. It's going to help open up your alveoli, which is going to help create that space for gas exchange. This is great if the patient's going through that refractory hypoxemia, right? So remember, just as a review, refractory hypoxemia, no matter how much oxygen we give the patient, it's not going to benefit them at all, because our alveoli are either collapsed or fluid filled, and it's just not doing anything. Okay, it's not going to do anything for the patient. We need to give those alveoli a chance to re-expand and give the alveoli some space for gas exchange, right? We do need to be a little careful due to some fluid shifts. As we're turning the patient to a prone position, the patient can become a little bit more hemodynamically unstable. They can definitely drop their blood pressure and even have like a chance of dysrhythmias. So just be aware as a nurse that this can happen when we do prone patients. Patients are proned for 16 hours a day. They're in the prone position, and then they can get turned back to a sideline position. So after proning, patients should be placed in a sideline position after. They shouldn't be placed back in a supine position. This is a big deal. It takes a big team. We want at least 3 people on each side to help with the turning process. We need respiratory therapy at the head of the bed to maintain the airway and make sure that we don't lose the airway of the patient. It's very structured. We need to be careful of lines, tubes, and also the skin integrity of the patient is a big deal. So placing pillows underneath the chest, the abdomen, the knees, the feet, we really want to create that offloading pressure so the lungs expand to the best that they can, as well as the alveoli. We want to make sure that our sheets underneath the patient are pulled tightly, that there's no creases or wrinkles or lumps. That could be a huge increase for skin breakdown. Also the face. In the next few slides, I'm going to show you, some pads that we can use to help with taking pressure off the face and preventing breakdown of the face. Typically for the arms, we place the arms in a swimmer's position. So whatever side the head is facing, say if your head is facing towards the left, that left arm is going to be down. The right arm is going to be up. And then if you turn the head to the right arm is going to move down, the left arm is going to move up. So that's the swimmer's position. Sometimes both arms can be placed up above the head for some time, or both arms can be placed at the sides of the patient as well. Electrodes can pose a huge risk for skin breakdown, so we should really place them on the back of the patient. We can get just as a good reading on the back as we can on the front. Patients who are in the prone position need to be paralyzed. They need to be on a paralytic if they are going to be proning. It's just it's a long period of time to be on your belly, but it is so beneficial to our lungs, and it has to be done in severe ARDS cases. So moving on to the slide, it's just showing you some facial pads or gel pads that can be used to help with any skin breakdown or skin integrity. Again, pillows under the feet, knees, and abdomen is very important for offloading of the patient. And this is just an example of a patient being prone. As you can see, we have a lot of lines and tubes that need to be properly placed. This patient has the blue and white pad. As you can see, it has like a few areas for tubing to come out of. So it makes it a little bit easier for tube placement, especially for OG tubes and the ventilator tubing. And here we are with another patient. You can see the electrodes are placed on the back. His arms are both above his head in this picture here. And on the slide I was talking about on proning, there is a nice video that shows you a step-by-step on how a facility prones a patient. And again, it's very detailed and involved with many team members at the bedside. So we're going to move on to mechanical ventilation, okay? There are two videos here. I believe one video is showing you the intubation process, okay, how a patient is intubated. And then the other video is showing you the settings on the vent. And that's a pretty helpful video to go over. So ventilation, mechanical ventilation, it's positive pressure ventilation. So what happens once the patient has an airway and has an ET tube? During inspiration, the vent is going to push air into the lungs under positive pressure, and then expiration occurs passively. Okay, so the whole intubation process, we try to do this before it's an emergent situation because we want this to be as controlled as possible. Best practice today is that we use what's called RSI. It's rapid sequence intubation, and it's the most preferred method today to use for sedating patients prior to placing the ET tube, okay? We want the patients at a comfortable level. We want them to, not have much of a gag reflex because that's going to fight the ET tube going down, and that's going to also cause room for vomiting, and in turn the patient's going to aspirate. So RSI is very, very helpful in preventing, any trauma and as well as aspiration issues. Rapid sequence intubation is typically done with a sedative, either propofol is the most typical. Sometimes a paralytic drug is used concurrently with the sedative, and of course we need a pain management, typically fentanyl, okay? So sometimes propofol is used. We'll use etomidate as well as fentanyl to blunt the pain. Once the patient is sedate enough, our respiratory therapy will be bag masking the patient, keeping their oxygenation level at an appropriate level. And then either the respiratory therapy or provider will be placing the ET tube into the patient. And once the ET tube is confirmed and placed, a balloon is inflated so the tube stays in place and the patient is connected to the ventilator. Okay? So that video above kind of shows you a more detailed, it's long, step-by-step procedure of how a patient is intubated. So just nursing in general of what we want to consider once a patient is ventilated and intubated and ventilated is we want to provide that good balance of sedation and analgesics, using paralytics as needed, and we need to assess and titrate as needed as well. We want the patient to remain comfortable. We don't want them to be in any pain, and we don't want them to be fighting the ventilator because it's not any benefit to the patient, and it's not going to help the patient heal. Especially if we're talking about an ARDS patient. Remember what we said, we want them sedate as much as possible, sometimes to the point of a paralytic, just because we want their lungs to recover as well as they can, and we want this patient to be down and sedate during this time period. So it's important to auscultate breath sounds, while the patient's intubated. Monitor their respiratory effort, making sure they're not fighting against the vent or they're not asynchronous against the ventilator. Monitor for any ventilator settings and alarms, and be cautious for alarms. Determine the need for any endotracheal suctioning. Typically, we do this every 2 hours along with mouth care, depending on how much secretions the patient is having. Sometimes we may need to suction the patient almost, every 30 minutes. So that's very dependent on how much secretions the patient is having. And you'll be able to tell that. The ventilator typically will alarm, and we'll go over the alarms if there are tons of secretions that need to be suctioned. As we are suctioning the secretions, it's important to look at the color, the amount, the consistency, and document that as you find. And also repositioning that ET tube as needed. So that endotracheal tube kind of sits a little bit on the lip of the patient. And we don't want that in the same spot for too long. And respiratory therapy does a wonderful job of moving that ET tube around as needed. We want to prevent any skin breakdown on the lip from the ET tube. Continuing to monitor ABGs, and we kind of change the settings as ABGs change. Okay, so as ABGs change, we may need to change the ventilator settings as well. Providing enteral nutrition while the patient is intubated, assisting with early immobilization if they can tolerate that, providing range of motion and turning repositioning if they cannot get out of bed, and providing that oral care with the chlorhexidine every 2 hours is very important. And here's a picture of just some patients, if they can get down off of the sedation well enough and they can get up and walking, that's the best thing to do for patients, is to, mobilize them. ICUs are getting a little bit better at this. Yes, it's very difficult. Yes, you need a team of people to help you with this. I mean, look at all the lines and tubes and machines that nurses and staff need to carry along with the patient. But it's so beneficial. It's so good for the lungs and even the muscles in the body just to move around. And I just wanted to show you a picture of an endotracheal tube that is on the left side here. So that top part, it says the connector to the oxygen source. That's where that's going to connect to the vent tubing. And then the long plastic tube is, the ET tube itself. And as you can see, there's numbers along the tubing, and they typically go up by twos. We have 18, 20, 22, 24, and that's just the length of the tubing. And it's a very important measurement for nurses because we need to know where that length sits at the lip. And that's important because we want to make sure that endotracheal tube hasn't moved at all, okay? If we see a difference in even an inch to, an inch to 2 inches, that's a big deal, and the patient might not get the correct oxygen that they need. That little valve that is hooked up to that string, that is going to help inflate the cuff. So you put a little air into that valve, and that cuff at the bottom, it will inflate. And that's really about it with the ET tubes. This one doesn't have a high-low tube. A lot of the newer ET tubes, they call a high-low tube. And a high-low tube actually connects to a suction container separate from the ventilator. And that just helps with increased mouth secretions. And it decreases in any ventilator-associated pneumonias. And that's why they've added them to the newer ET tubes, is to help with VAPs. On the right side here are actually different size blades that a provider can use, or RT can use, to help intubate the patient. It keeps the mouth open to place the ET tube. These are MAC blades. Most blades are all plastic and throwaways. Typically what we have on the ICU are definitely throwaways. But I think some blades that are in the emergency carts may still be metal. I know the OR uses metal. Maybe some other places do as well. But the metal does go down to central sterile after it has been used to be sterilized and cleaned. And next we have these are wonderful. So on the left-hand side, we actually have these new um, handheld glidoscopes, which are lovely. It has a camera right on them for the provider or RT to see right down into the airway to be able to intubate a lot better. It has so much better visualization. And these are handheld and they're battery powered and they're wonderful. And as you can see at the bottom of them, that's a plastic throwaway blade to keep the mouth open while you're intubating the patient. On the right hand side, these are stylets and these are metal. And what a stylet is very helpful for is it actually creates, you know, more stability with the ET tube so it's not as floppy. And you can insert the ET tube a lot more easily into the patient with that metal piece. And then that is pulled out right after you have inserted into the airway and you've made sure that you do have an airway. And then those are sent to central sterile to clean. And this is an example of just a bigger glidoscope. The ICU does have one. I'm not sure if any other areas do, but this is almost the exact one we have, pretty similar. And as you can see, it kind of holds the handheld glidoscope. It has different, I think it has a bronch along with this as well. So it's a wonderful new piece of equipment that we have. And here's a picture of a ventilator. These ventilators we do have at Berkshire Medical Center and are frequently used in the ICU. I know we did go over some settings in that video. Definitely talks about the settings on the ventilator. But remember, as a reminder, the ones that I want you to be aware of is the mode, which is what we talked about. The most important ones we really talked about is AC and spontaneous. And we talked about pressure control with ARDS. Okay, so assist control, also known as AC and spontaneous, are, really common modes on the ventilator. And that's just the, preset. Assist control is a preset frequency that initiates a breath to the patient. Yes, the patient can breathe even in between the set breaths, but that assist control is going to deliver that set amount of breaths per minute. Okay. Next, if you see the number 18 here at the, one of the bottom squares on this ventilator, that is just the respirations per minute. It's how many breaths, respirations a patient's going to breathe, and that can be set. That can be set a lot higher for patients who are, hypoventilating and are carrying on a lot of CO2. So it can help them blow off carbon dioxide a little bit easier. Next is tidal volume. It's the VT or the number here, 400. And that's just how big of a breath the patient is going to receive. And then if we move over, it says O2 here, 35%. That's the FiO2. So that's how much oxygen the patient will be getting. And then below that is PEEP. So that is what's going to help keep our alveoli open to create space, to create gas exchange, so we can actually be oxygenated. And the oxygen is actually going to do something when we give it to the patient. And we'll talk a little bit more about PEEP in a second with ARDS. We talked about spontaneous, which is kind of more opposite than AC. And if you remember, spontaneous control is, it's going to let the patient breathe on their own. And really what we're hoping for is that we have really no apnea at all in the patient. But if we do, if the vent does sense apnea and spontaneous, it will breathe for them. So really it's going to kick in when they need help. Okay. That's the difference of spontaneous, where AC is that set number of breaths will be delivered to that patient. So let's talk about mechanical ventilation with ARDS specifically. Okay. So the mode of ventilation for ARDS that is preferred is typically pressure control. Again, this is provider specific or respiratory therapy specific, depending on the patient. But typically pressure control is preferred. It helps keep inspiratory pressures and plateau pressures from becoming too high. It also helps prevent any alveolar distension and rupture, and also barotrauma. Okay. It does not allow at all for patient-initiated breaths. So if you can remember this, think about how much we want to the lungs to rest. So if pressure control is not going to allow for any initiated breaths whatsoever, we're allowing those lungs to rest at the highest level we can. So the inspiratory flow pattern decreases, we're reducing peak pressures and, hopefully improving gas exchange with this pressure control. Typically tidal volumes are lower. We deliver high tidal volumes to non-compliant stiff lungs. We're going to be looking at barotrauma. We're going to be looking at possible overdistension and rupture of our alveoli. So we need to be pretty careful with our tidal volumes, and typically they're lower. The only thing with lower tidal volumes is our PaCO2 levels on our blood gases may tend to rise. That's due to permissive hypercapnia. If we're getting a PaCO2 level up to 60, that's pretty much okay for patients who are in ARDS. We're going to need frequent ABGs, of course, for any patients who are intubated, but most significantly for ARDS patients. And this tidal volume does help us figure out a proper respiratory rate for the mechanical vent as well. And then when we move to respiratory rate, typically it's a higher respiratory rate for ARDS patients. Again, that's provider specific or respiratory therapy specific. And FiO2, that's all dependent on how hypoxic the patient is, how much oxygen we want the patient to receive. Typically, we're giving higher levels of FiO2. Okay, we're up in like the 80% range, 60 to 80%. These patients are very, very that's the word I'm looking for. Unstable, I guess. They're not stable in oxygenation, and it can change very, 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 very quickly on a dime. And PEEP. PEEP is very, very important for ARDS. This is really what I want you to hone in on. 5 is actually just very, very common. When you turn on the vent and you set up anybody for a vent, they should be at least getting a little bit of positive pressure, a PEEP, and that's going to be 5. Very common for any atypical ventilated patients. ARDS patients typically need high levels of PEEP. We need to help open up those collapsed alveoli, and that's going to create room for gas exchange. We kind of can increase in increments of 3 to 5 until our oxygenation is adequate. So once we start to see our oxygenation improving, our PaO2 improve, and our SAT levels improve, it means we're doing okay on our PEEP level probably, okay? If we're still not oxygenating well, we probably need to go up on our PEEP, right? Because those alveoli aren't opening up well enough. We want an FiO2 60% or, we want our FiO2 to be set at 60% or less. Yes. So PEEP levels can be 10 to 20 in ARDS patients. 10 is pretty high, 20 is very high. High PEEPs, actually, we need to just be cautious of this. They can actually dramatically reduce cardiac output and blood pressure, so patients can become a little bit hemodynamically unstable if PEEP levels are high. That's why vasopressors are pretty important and used a lot in ARDS patients as well. And we're going to go over ventilator alarms, and this is really all I want you to know for vent alarms. We have high pressure alarms. So this is when the pressure required to ventilate exceeds the preset pressure. So this is a potential cause of a pneumothorax. The most common cause you'll see with high pressures is excessive secretions. So you just need to suction the patient, and hopefully that will help with the vent alarm, or any decreased lung compliance. So we may see this in ARDS patients who are severely non-compliant with their lungs, severely fibrotic. Then we have our low pressure alarms, and this is resistance to inspiratory flow is less than preset pressure. Okay, so it's not exceeding, it's less. So this is a disconnect. Okay, so the ventilator is disconnected. There may be a break in the circuit. And then there's a low exhaled volume. Exhaled tidal volume drops below preset amount. So this could be if there's a leak in the system, any increase in airway resistance, or a decrease in lung compliance. There's an apnea alarm. So we may see this a lot on patients who are on spontaneous breathing trials. Their respiratory rate, drops below a preset level, and they have a period of apnea, and that's going to alarm. So the client can be fatigued, right? So if they are having spontaneous breathing trial and they've been doing great all day long, and all of a sudden they're getting pretty tired in the evening and they're not breathing as well and they're setting off the apnea alarm, it kind of makes us, maybe we should turn them back onto assist control to help them out a little bit more. Okay, so that's kind of an example of how we can use the apnea alarm. Any decrease in respirations, sometimes even over sedation. So are we giving the patient too much sedation? Typically, if they are on spontaneous, they really should be on very, very low levels of sedation, if any. The patient needs to initiate that breath and know to breathe on their own. So they really cannot be sedate at all. And then if we have FiO2 alarms, this indicates an FiO2 drift from the preset range. So again, this can be changes in the level of consciousness. There can be a disconnect from the oxygen source or a break in the circuit. So going back to VAPS, what are the signs of ventilator-associated pneumonia? We can have a fever, right? So fever, high white blood cell count, purulent sputum. The sputum can be odorous. Do we hear an increase in crackles or wheezes that have been different? Do we see new infiltrates on a chest x-ray? All these findings are signs of ventilator-associated pneumonia. And we know that once the patient is intubated and then they show these signs and symptoms, what's the time frame for VAP? 48 hours, right? So 48 hours post-intubation, if they start to show these signs and symptoms, probably definitely thinking about a ventilator-associated pneumonia. Typically, gram-negative bacteria is associated with VAPS. Most commonly, we have E. coli, Klebsiella, and Strep pneumonia per sputum cultures. And we can, unfortunately, VAPS may happen. We can have contaminated respiratory equipment, perchance. That's why a lot of kind of throwaways today are a little bit more helpful. I mean, we do have a great cleaning system in Central Sterile, but the plastic throwaways can help a little bit with contaminated equipment. Poor hand hygiene, of course, poor room ventilation. Those could all be reasons. Aspiration, right? If the patient aspirates, can be a cause for that as well. So how do we prevent VAPS? RSI, right? We can use rapid sequence intubation. Hopefully that will cut down on the need for any gagging, causing vomiting, causing aspiration, right? We can minimize sedation, especially when we do those sedation vacations in the morning, hopefully getting the patient off the vent as quick as we can. Trialing those spontaneous breathing trials, again, that means going down on the sedation and having the patient, put a little work into their breathing, getting them off the ventilator. Early mobility, if we can, if the patient can tolerate it. Head of the bed elevation, right? At least 35 to 45 degrees. Oral care every 2 hours with chlorhexidine and being consistent with that. and routine suctioning, especially if there are large amounts of secretion, both in the mouth and deep suctioning. Really, we don't want to be, changing the circuit too often on the ventilator. We want it to keep it as much as a closed system as possible, because that will bring in and harbor bacteria if we do open that up. And we talked about that high-low tubing a little bit too, right? So that tube that is connected to the newer ET tubes, those are connected directly to our suction containers, and that's going to help with large amounts of oral secretions, which can harbor bacteria as well. So weaning, I want to talk to you guys a little bit about weaning. So this is when the patient's kind of starting to be, they're getting better, okay? And we know that they're okay to probably get off the ventilator. But we need to see that there's some sort of reversal of the underlying condition, right? The underlying cause of the respiratory failure. We need to see improvement in that. So for examples, how's the chest x-ray looking? Does it look better? Are their secretions getting better? Are they clearing? Are they getting a little bit more alert? Can they follow commands? Are they having adequate oxygenation? So we want to see the settings down on the ventilator as well. So our PEEP level, it should at least be down to 5, right? We shouldn't be weaning anybody off the vent if we're not down to our minimal level. Same thing with FiO2. We should be down to at least 30%, okay? They should be requiring minimal FiO2 to be weaned. Our pH on our ABG should be greater than 7.25 for sure. Our SpO2 should be greater than 90, depending on the patient's baseline for sure. I mean, if they're COPD, they may live there. But if not, we would like to see them above 90. They need to be hemodynamically stable. If they're dropping their pressure and still needing pressors, really probably not ready yet. Can the patient initiate some respirations on their own? So when we do that sedation vacation and we take them down on the sedation that they're on in the morning, and we put them on spontaneous, can they initiate some breaths, or are they going to fail right away? Okay, so that's what we're looking for. Are they going to fail? Are they going to need to be put back on AC immediately, or can they maintain spontaneous for a little bit? How's their neurostatus? Are they kind of, coming back to a more controlled neural status? Are they following commands? Do they seem more alert? Do they have a cough and gag? We don't want to extubate anyone who doesn't have a positive cough and gag, because they're going to be right back intubated. They're not going to be able to control their secretions. They're not going to be able to have a good cough or provide a cough for us. And that's just going to lead back to a horrible aspiration issue, and the patient will become even more sick. So by, deep suctioning the patient, we can see the patient gag a little bit and have a response to deep suctioning. Or if we're doing oral care, we can maybe stick that tooth a little bit down into the back of their throat and see if we can initiate a little gag from there while we're doing an assessment. We want to make sure that the patient has minimal secretions. If they're overloaded with secretions, we're probably going to end up right back where we were and intubate the patient again if they can't handle any secretions. So spontaneous breathing trials, like we talked about, they're going to be placed on the mode of spontaneous, and the patient's going to be breathing on their own. If they do poop out, if they get tired and fatigued, the machine is going to kick in for them if it recognizes any apnea, okay? So it's going to help them out when they need it. Typically, we start them off first thing in the morning, and we see how long they tolerate. Some patients need spontaneous for a few days. Sometimes we need to exercise their lungs, get them used to breathing on their own. Sometimes it's not going to happen in just one day. They're not going to be extubated in just one day. They need a little bit. They need some time to get used to breathing on their own again. And sometimes we can initiate spontaneous breathing trials in the morning, and we can turn them back to assist control at night and let them rest overnight. Okay. Some patients who are ready to extubate can go on spontaneous all day and even through the night. Okay, and that's when we know they're ready. Okay, when they're not fatiguing and pooping out anymore. We don't need to put them back on assist control. So always assessing for that respiratory fatigue, and we know doing that sedation vacation is going to help us out greatly in knowing how well they're going to breathe spontaneously. This video, I have to be honest, I can't think of what this video is right now. I'm sorry, I can't think of what it is. It has something to do with ventilation, mechanical ventilation. And okay, so our last portion here, we're moving to trachs, okay, tracheostomies. So, excuse me. A tracheostomy, it's a surgically created stoma in the anterior part of our trachea. An incision is made into the anterior portion of our trachea to establish an airway, create a stoma, and place the trach through the stoma. Typically, these can be used to bypass an upper airway obstruction. They can be very beneficial in facilitating removal of secretions, and they're also beneficial if the patient does need more long-term ventilation, and it helps with weaning off the vent if the patient does need longer time on the ventilator. We really don't want to keep patients on an endotracheal tube any more than 2 weeks. First of all, it's going to harbor a lot more infection. So we don't want to keep them long term with an ET tube. It's going to place, it can start to, increase the risk for injury to the vocal cords or the airway itself. So that's why we need to minimize a tube in the airway or in the mouth as well. So really after that 2-week period, we're really gonna, the patient may get a trach if they can't get weaned off the vent. So we trach and peg patients typically after 2 weeks. It's more comfortable for the patient. The trach is shorter in length and it's a little bit wider than an endotracheal tube. So it gives a little bit more comfort. The patient's not going to have that, thing in their mouth making them gag down their throat. So again, adding a little bit more comfort to the patient. Once the trach is in place, it's sutured and secured with cotton ties, or we have actually Velcro straps at Berkshire Medical Center. And this is just a picture of a video of a patient having surgery, getting a tracheostomy placed. And here is a picture of a tracheostomy tube being placed into the trachea, typically between the second and third tracheal rings. And then here is an image of a trach and kind of the parts of a trach. So you can see the trach tie strings, or at BMC we would see Velcro straps. The flange portion is what it kind of sits against the neck, the face plate or the flange. Then there's the obturator at the bottom, and that's kind of a hardened plastic piece. Remember we talked about the stylet with the ET tube, and it makes it a little bit more firm and stiff when placing the ET tube. This kind of is the same thought with the tracheostomy. The obturator, that hard plastic piece, is inserted into the trach, and it's a little bit more stability with inserting the trach into the trachea. We have that outer cannula, and that keeps the airway patent. And as you can see at the bottom, there's a cuff that holds the trach in place, and that is inflated by air. And there's that pilot balloon. It's that one-way valve which inflates the cuff and helps keep that in place, especially for mechanical ventilation. And that cuff is also going to help decrease the risk for aspiration. And it makes sure that the patient gets the volume delivery that they need for the ventilator. Typically, chronic trachs are uncuffed. We also have an inner cannula. They can be either disposable or non-disposable, and they're typically removed when cleaning is done on a daily basis. And that inner cannula kind of acts like a liner for the trach. There can be a lot of like buildup of mucus inside the trach tube and the inner cannula, so it's very important to take that out and clean that. That inner cannula also can lock into place and prevent any accidental removal. And then these are just a few examples of what is called, oh, God, I lost the word. Fenestrated. So these are fenestrated trachs. All different examples of one. You can see the one on the top does have a balloon with has balloon inflation. The one in the middle does not, and the one on the bottom it just is a different fenestrated hole. The fenestrations can help promote spontaneous breathing. If it's cuffed, when the cuff is deflated and that inner cannula is actually removed, air can actually pass through the vocal cords. It can help with the patient with speech a little bit better. So fenestrated trachs can allow a little bit better speech for the patient, and they can actually breathe a little bit easier spontaneously. And that is when the cuff is deflated. Okay. When the cuff is reinflated and the inner cannula is placed back in, air again cannot pass through from the lungs to the vocal cords, so speech will be, decreased. There'll be no speech once the balloon is inflated again and the inner cannula is placed back in the trach. But once the balloon is deflated and that inner cannula is taken out, those fenestrated holes can help with spontaneous breathing and also speech. We do not see fenestrated trachs as much at all anymore. Maybe a little bit more for long-term use or patients who have trachs, who've had trachs for a while. So potential complications for trachs, we can have an air leak. There can be an airway obstruction. We can have risk for altered body image, aspiration, bleeding, fistula formation. We can have an impaired cough, infection, tracheal necrosis, and also tube displacement. So just some things to keep in mind with nursing and nursing care. Trachs should really be assessed at least every shift. They should be part of your assessment with the patient, and it's important to always confirm that patent airway. We want to make sure to observe the site around the trach for redness, any inflammation going on around the site. Is there edema? Do you see any ulcerations forming around the site? Is it draining or is it oozing? Is there any signs of infection or any bleeding? Suctioning should be performed just on an as-needed basis for the patient. We always want to make sure we hyperoxygenate the patients prior to suctioning and following, suctioning to prevent hypoxemia. So prior and after, it's important to hyperoxygenate the patient. Closed or inline suctioning really helps to maintain oxygenation during mechanical ventilation. And if the patient is still hooked up to a mechanical vent, that suctioning line is going to be closed. So that's going to be contained. When suctioning a trach, we use a catheter that's no more than half the inner diameter of the tube, and we insert it just beyond the end of the tube. Okay? And typically, a size 12 French suction catheter fits most patients who have a trach. Some facilities have respiratory therapy to help with care of trachs. I know, BMC respiratory therapy is wonderful, and they help so much with the personal care and daily care of tracheostomies, and nursing does as well. So when caring for a patient with a trach, nursing care includes suctioning of the patient. We make sure that we clean the skin around the stoma. We're providing that oral hygiene, which is very important, and assessing for any complications of the trach. It's also very great if we can provide, humidified air, oxygen. We can use that. It's called like a T-piece or trach collar, and that can give that good humidification to the trach. Also along with appropriate fluid intake too, which is very important. That will promote any thinning and mobility of secretions that the patient may have and prevent any mucus plugging. It's just important to be aware too. A tracheostomy is a foreign body. Our body isn't used to having a plastic piece in our trachea. So it's most likely, secretions will form around the tracheostomy tube, and that's just a normal response from our body. So that stoma area must be kept clean and dry. It's going to prevent any breakdown. Some providers do like drainage sponges around the trach. A lot of new surgical providers do not. They don't like any sponges or gauze pads around the tracheostomy site. So that's provider specific. So, like I talked about, that peristomal care, the area around the tracheostomy, the skin, um, that should be completed at least at least every 8 hours, also known as every per shift. So you're going to just moisten like a cotton tip swab, or it can be with a gauze pad, and that will be with sterile saline. And you clean around the trach site and the stoma. And you can clean actually around the outer cannula of the trach as well, and the faceplate. The peristomal area should be cleaned in a semicircular motion, in an inward to outward direction. And we also want to dry it too. We don't want to leave that area moist. That's going to just harbor bacteria and cause irritation and breakdown. And again, we want to assess the skin for, any signs of infection or irritation. And we want to change those, if those, tracheostomy straps, like the Velcro straps, those can get dirty. So it's important to change those out every once in a while if they're soiled or wet, especially if they're wet. We don't want any, rash to form or breakdown or irritation on the skin. And when securing those trach ties or the Velcro ties, we should make sure that, just one finger should fit between the patient's neck and the tie. And sometimes, it's important, like I said, some providers are different, but this should be provider specific. Some like a clean pre-cut dressing, typically one of those drainage sponges underneath the trach area. Some providers do not like them. Okay, so we just need to make sure which provider requests what. We want to make sure we don't cut any gauze underneath the faceplate. That can cause frayed edges of gauze and cause more irritation to the skin. It's always important to document your trach care that you did that for your shift, and include the appearance of the skin. How does the skin look? And also put whether or not you changed the trach ties or the Velcro straps. And also, did you clean the inner cannula as well, which we'll get to in a second. If there are secretions coming from the trach, it's important, just like you do the ET tube, to document, the color of the secretions, the odor of them, the consistency, the amount, and also the frequency of suctioning. How often do you have to suction that patient? So for the inner cannula cleaning, we have cleaning kits. Okay, so you want to attain a tracheostomy cleaning kit for especially non-disposable inner cannulas. Typically today we have disposable inner cannulas, which we can just change in and out. But the cleaning kits do contain a brush and a pipe cleaner for that inner cannula if it's non-disposable. Okay. So we want to make sure that we clean all the secretions off the inner cannula using a sterile solution. Generally, it's a saline solution. Some institution policies recommend a full strength diluted hydrogen peroxide for the non-disposable inner cannulas, but that's dependent on your facility and where you work. So make sure you check the policy for that. Let's see. So if your patient has a tracheostomy tube with that disposable inner cannula, you'll just need that new sterile disposable inner cannula of the same type and size, of course, right? So you're just going to switch out the same type and size with the old one. Some tracheostomy tubes will require a temporary inner cannula while you're cleaning the non-disposable one. So something to keep in place in the trach while you're cleaning the one that should be going back in. Okay, and that's just a picture of a cleaning kit for a non-disposable inner cannula. And you made it to your last slide, guys. Oh my goodness, a lot of content. This is about kind of accidental decannulation. Okay, so what if our trach comes out? So if our we have tube dislodgement or accidental decannulation, it's always important to assess the patient first. How's their ability to breathe? You know, are they really have that increased work of breathing? Is this a respiratory distress issue, or are they okay? You know, are they stable? How's their level of consciousness? Are they in respiratory distress? So emergency supplies should always include a tracheostomy tube of the same type and size as the one currently in place. So any patient who has a trach in the hospital should have an extra trach of the same size at the bedside, just in case we have a dislodgement, okay, or decannulation. Also, there should be a size smaller as well at the bedside, okay? If the tracheostomy is less than 7 days old, so if it's fairly new, it may be very, very difficult to get a new cannula in the in the trachea. It really may be difficult to replace the tube if there is accidental decannulation. So an appropriate size endotracheal tube, ET tube, should also be at the bedside, and lubricant should be ready as well. Okay, so a lot of things to think about when a patient has a trach. So we should have a same size at the bedside, we should have a size smaller, and we should have an ET tube there just in case as well. If we can't get that trach back in place, we need some sort of airway, right? Okay. If there is dislodgement, we should be placing the patient in a semi-Fowler position, you know, making sure that they're, you know, we decrease the work of breathing the best that we can. We should be covering the stoma with a sterile dressing and providing ventilation by a bag mask. Okay, so we need to ventilate the patient by some sort of means, by oxygenation, and a bag mask is most useful for this type of deal. Think about it. If the patient's had a total laryngectomy, we need to ventilate the patient actually through the stoma. It's not going to do any good if we're ventilating more of the upper airway, right? It's very important that we do not change the tracheostomy tapes for at least 24 hours after the procedure, if that's a new trach. And we always should have suction equipment available. Gloves should be available. Like I mentioned, a bag valve mask, as well as tracheostomy tube ties. Other securement devices should also be available. All right, so any questions, please email me. I'm always happy to answer questions. I hope this has been enough content for you. I know this is a lot of stuff, but I hope it's made sense for the most part. It's hard stuff. This is hard material, but I think you all did very well with this in class. I'm pretty impressed by your answers in class. And again, just email me if you have any further questions. Thank you.